Secretary Galley.
Okay. All right. So good morning, everyone. I have to say I like the morning meetings better than the afternoon ones. I think our friends on the East also might enjoy that too. So thanks for everyone making this the way we're starting our day with our November meeting for the Healthy California for All Commission meeting. Before I jump into intro comments, if I could turn it to you, Karen, to take roll. I'll just warn, as I had told some of the commissioners and the public, we had some last minute cancellations by commissioners. So we'll be missing, I think, 3 or 4 for the entirety of the meeting. And then I know some of you reached out to let me know that you won't be on camera for some bandwidth, broadband related issues. So understand that as well. But thank you all for participating. Karen, if you could take roll, thank you.
Yes, thank you, Secretary Galley. And if I may first just very quickly go over some Zoom protocols. As you all know, this meeting is being recorded and it will be posted on the Healthy California for All webpage soon. Commissioners, of course, you have the ability to mute and unmute and the option to use your cameras, which we know you will if you're able to today. Of course, please keep yourselves muted when you're not speaking to reduce background noise. Please do use the raise hand feature if you're able to, which is clicking on the reactions icon at the bottom of your Zoom screen, and then you'll see the raise hand button as an option. Members of the public, welcome this morning. You are in listen and view mode for the meeting. We will be inviting public comment today at the end of the meeting, at which time we will open up the chat feature for real-time written comment. We will also be inviting verbal comment and explaining how to use the raise hand feature at that time. And of course, you may always provide written comment at the email address healthycaforall@chhs.ca.gov. All public comment taken today will also be part of the public record and posted on the Commission webpage. All right, and with that, I'm going to take roll call now. When I say your name, if you could just unmute and say hello, that would be appreciated. And we'll start with the chair, Secretary Galley.
Good morning, Karen. Great to be here.
Carmen Comsty.
Good morning, everyone.
Jenny Chin Hansen.
Good morning.
Bill Shao.
Hi. Good to be here.
Richard Scheffler.
Good morning.
Andy Schneider.
Morning, everyone.
Sarah Phlox.
Good morning.
Kara Desert. Commissioner Desert, are you able to unmute?
Good morning. Hi.
Good morning. Antonia Hernandez.
Good morning.
Anthony Wright.
Morning.
Richard Pan.
Present.
Jim Wood.
Present.
Michelle Boss.
Morning.
Rupa Maria.
Good morning.
Thank you. And again, just for the record, the advance notice of those commissioners who couldn't be here today are Commissioners Peter Lee, Don Molds, Bob Ross, and Sandra Hernandez. And with that, I'll turn it back to you, Secretary Galley.
Great. If we can get the slides back up. Perfect. Let me, before we get into some substance, I just want to acknowledge I've had the privilege of doing this with so many of the groups I've been engaging with over the last couple of weeks, but just start by, in this week of preparing for Thanksgiving, just thank all of you for the tremendous partnership and collaboration, the time investment all of you have made in the commission, not just the meetings, but also preparing for them, conversations about how to make sure that we're moving in the right direction. And then also the surveys. We'll get into a little bit of the second survey in just a few minutes, but I just wanted to say a real heartfelt thank you to each of you for making the commitment to helping us navigate this very important conversation and set of commission meetings. And then I'll also just offer thanks to the public who join us each of these meetings, patiently listen and provide the public comments at the end of the meeting. It comes together to be a complete package that I think helps us move forward. I also want to thank the consultant team that supports me and my staff, and then also the work of the community engagement work that happened because of our foundation partners, but also those entities that help put that work together. I think it does take a village to get this work done, and I just want to say thank you on the eve of Thanksgiving that we acknowledge the tremendous work and sacrifice many of you make. I know that you're canceling other things that you could be doing, having people fill in for you in your other responsibilities. So just a real deep appreciation for what it means to be able to do this work in a privileged way. So if we could go to the next slide, please. So today's agenda, really, I want to spend some time right now sharing with you the next steps as we kind of come down this home stretch of our meeting time. I know many folks are wanting to hear how we will bring it all together, what the process will look like, how you engage in that process, etc. Also want to share some time to reflect on what we've accomplished together, and then highlight some of the areas that I found most important, interesting in my brief review. I've gotten through half of the survey questions and comments from the commissioners. Be honest, it's a lot of good information. It takes a while to get through, but I want to highlight some of the important areas of alignment, and then some areas where we have some more work to do. And then we'll enter to our featured sort of conversation around financial sustainability under unified financing. Ken Jacobs from UC Berkeley is going to be walking through some slides that I know many of you had a chance to review just prior to the meeting. So could we go to the next slide, please? So the recent survey round 2, again, just appreciate everybody for taking time to thoughtfully consider the questions. I think we saw a lot of movement in this survey. What we did was take the prior survey, refine some of the questions. I appreciate everybody following the assignment well and rereading and seeing how some of those questions changed, because I think it was meant to reflect the feedback from the first round of survey, and then also raise some questions and important areas, propositions, goals that we wanted the commissioners to reflect on that have come up since that first survey. And as I said, these responses are not just thoughtful and important in the theoretical, but I think will help us move the final report forward. We had a lot of excellent suggestions on how to elaborate some of the proposals and propositions and key guiding principles, and then also how to be more exact and specific with our language. I appreciated the sort of wordsmithing exercises that some of you really took to heart to make sure that we use the language that matters most to guide where the commission ends up. And then I'll spend a little time in just a moment, but just so everybody knows, we will be posting these just like we have the prior responses on the website shortly. You'll have a chance to see what your fellow commissioners have sort of said on each of the questions, and then also for the public. And just fair warning that this won't be the last one. I think it's such an effective tool at getting us to have some meaningful dialogue and back and forth around issues that come up in these meetings, that we will likely administer what will be a shorter survey in all likelihood, but no promises, on some of the current areas that we will be discussing, and then also opportunity to further clarify some of the issues and language that came up. If we could come to the next slide. Actually, before we get into next steps, I just wanted to, like I said, I had the chance to review about half of the survey results. And I think there was a lot of great comment, and I wanted to talk a little bit, and you'll see this on a future slide. I think the commission is really moving very successfully. It's not perfect, like perfect alignment. There's still some questions, but this idea that we can and should move towards a unified financing system for healthcare in California is really emerging as a true opportunity for us, which I think is not for some of you a new idea, but to get this kind of movement on the commission, I think is a huge deal for us, given where we started. I think some of the concerns or questions people had early on, I think you'll see when you look at those survey results that there's a lot of consensus. I think we saw a lot of consensus, also lots of agreement, maybe some slight modifications on the values that we've talked about, things like around quality and equity and universality, and making sure that we capture some of those really guiding principles that we started with. But I think as we've gone along, we've refined some of those concepts, and I've been pleased to see how focused the responses are there. I'll tell you that there's also a lot of consensus on the power of payments and how the payments need to be used as one of the primary, most important tools to drive towards the goals that we see. So really being thoughtful about what payments look like, not just who receives them, but how they're received, to drive around issues of equity, quality, access, and many of the things that I think our community engagement work identified around balancing power within the healthcare delivery system that deepens and drives not just individual, but really population-based inequities that we're facing. I'll tell you some of the areas that I think we have more work to do. There's healthy discussion around integration and not confusion, but do we mean integrated systems or do we mean integrating care? And what's the difference between integrating care and coordinating care, and who's in charge of doing that? Is it an entity that lives above, like a plan, or is it really done at the provider level or the practice level? So I think these are really important areas that we're going to continue to struggle with and come to hopefully more understanding and as much as possible agreement, but certainly prepared to represent the full flavor of the perspectives. Another area that I saw was obviously we've spent some time talking about it, and it comes out in the survey responses as well. What is the role of health plans? Should we have health plans? How do we imagine them differently? I think a healthy set of perspectives, many different from one another, but I think largely saying, and this I think is a consistent theme, that the way we have certain plans functioning today, that in order for us to achieve the kind of system we want to see, there has to be some transformation at a minimum. So I think that's going to be an interesting and important set of conversations and points that we think about. There was more consensus on this than I expected, and without saying exactly where I land on it, I will say that I think a lot of folks were pretty clear that we can expect the healthcare delivery system to really address a lot of the, with its funding, a lot of the social drivers of health. And I think this is an interesting tension that I think many of us in the safety net are struggling with, on how much do we look to the health, the health landscape to help support and address certain social drivers of health. Think questions around whether you can have a high functioning system, healthcare delivery system, if those social drivers of health aren't attended to in one way or the other. So I think this is another place where we're going to see some real consistency, but I think some then open questions about where we go next. So those are some of the, I think, just high level points that you'll see coming out of the survey. I wanted to highlight those because I do think they're going to become the crux of some of our conversations, really trying to drill in the next survey. And I'll be determining how much of these specific areas we need to grapple with in as soon as some of our December meeting, when we potentially focus on transitions. I think some of these areas will come up. So be prepared for that. But just really a deep thank you to all of you for spending the time giving such thoughtful responses. And I hope you enjoy reading them as much as I did. I would advise starting a little earlier than 9 p.m. because you may not go to bed promptly. It's a lot of content. Okay, if we could go to the next slide. I know I've now taken us a little off track on time, so I'll be a little faster. December 9th, our next meeting. We have the potential topic of ensuring a smooth transition. Really something we've spent some time talking about, but how do we get from where we are today to where we want to be? What are the important features? And I think some of the issues that come up in the survey results are going to be front and center in this conversation. As I mentioned, we'll likely have a potential survey going out to commissioners sometime in the middle of December. And then I also want to tell you that we intend to send commissioners an outline for the final report. This will be high level. I don't expect it to be more than a single page with just what are the areas, what's the flow of the report looking like from my perspective. How are we going to, what areas we'll address? I think I've already told you that in some places under each of the areas that we'll be able to discuss in the report, it will really highlight where we've come by way of consensus and where there's lots of agreement, and then be able to outline where there is a diversity of opinions in some of those statements. And then some focus on what it means to take this to heart and what some of the next steps might be for California to consider. Then commissioners should know that we will be sending a draft report, what gets built up from the outline sometime in the middle of January. I know we were scheduled to have a mid-January meeting, but given just the timing and the hope of giving most of you, all of you, a bit of a break reviewing things at the end of December and early January, we're going to move that meeting to late January. And then in all fair warning again, consider whether we would benefit from having a final wrap-up meeting in February. So we'll keep you all posted as to that timeline, because I know schedules get tight and we want everyone to be able to attend. Next slide. So I wanted to, some of this came out already, but I just wanted to put it on a single slide. All of you have seen it, but these are some reflections I've had on where we've come and sort of what we've been able to have a conversation about. I think in the what we want column, I think we've put out there a system that's really universal, that provides all Californians the healthcare they need and deserve. And I think the word deserve is important because I think certainly those of us in healthcare understand that what people perceive as needed isn't always available. And so we have an opportunity to really build that universal coverage, making sure that it's low or no cost to Californians, and that there's equal access for all Californians to this vision and dream, and that it has no barriers based on some of the traditional barriers that we deal with today. And I think, frankly, frustrate commissioners, the public, and people across California, that we create a system that puts people first and uses these resources wisely. We've talked a bit about the range of potential provider reimbursement approaches. We've talked about hospital global budgeting. We've had a fair bit of debate about what form payments should take. I think we know, though, as I said earlier, that payments give us this important opportunity to address some of the instability in the healthcare delivery system, the inconsistency, certainly drive around issues of equity, and the issue that I think came up loud and clear in our community engagement work around the power imbalance that drives some of the outcomes we see in healthcare. So really thinking about how we use these resources to drive towards those needs. That we aspire to have something that is certainly less complex and reduced administrative burden compared to where we are today. We heard this loud and clear as well. I think what this really ends up looking like in one part is a single set of rules for consumers and providers, that we're eliminating some of that administrative activities that we know don't add value to care, and really looking hard at what can be done here. And then sort of addressing the front end of how we raise the funds for our healthcare system, that it is really led around an equitable financing approach, that we've talked a bit about broad-based ways to raise funds that would substitute for the current way that we pay for healthcare. And I think this is going to be an important part of today's conversation. We spent a good bit of time talking about how the structure of not just how we raise the funds for the system, but also how we pay them out is going to drive the outcomes that we want. I think I can name a number of the commissioners who have been very vocal around what we might do with those payment opportunities. So I think that these are just some high-level reflections to really punctuate for all of you the tremendous progress I think we've made. I know that there's interest in continuing to beat the pavement and make even more progress, and I think we will. And as we come together to bring the final report, I think a lot more detail will be added, but this is just an initial set of comments for us to be thinking through. Next slide, Karen. So before I turn it over to Ken, I wanted to just take a moment and tee up this conversation. We spoke in September about the need for deepened federal engagement, what that would look like, who at the federal level, is it agency, is it Congress, what we need to be asking for. In August, we discussed some of the ways funds from within the state could be redirected to contribute to a system of unified financing. And today, I think we have an opportunity to look at another area of concern, which is not just how do you bring all the dollars together, but what do the forecasts look like to have the finances that we have come to expect today really help carry us forward, as well as issues around how we deal with questions of stability and making sure that not just we're able to get started with a unified financed health delivery system, but that it's sustainable over time. This will raise some important questions that we'll deal with after the presentation, that looks at what mechanisms, two questions that will sort of guide us with was what mechanisms should be used to reduce healthcare costs and growth. I know a number of you have ideas and been working on this issue for a long time. So I think we'll have a rich discussion. And then beyond cost containment, what additional structural changes should we be looking for to assure that we not only get the system that we want, but that we are able to sustain it over time. And this, I think, will lead us into beginning discussion around governance and how we would set up governance for a unified system at the state level. And I know a number of you have experience in setting this up along the way. So I want to turn it over to Ken Jacobs, who I quickly introduced at the beginning, or at least to the commissioners. Ken has been a trusted source of lots of analysis and information for California. He's at the UC Berkeley Labor Center. I had a chance to spend some time with Ken in preparing for this, and I think many of you will find what he has to share vital and important for us in the world of let's not bury the lead. I think that one of the things that you'll see in Ken's presentation is going with a unified financing system, and with some of the inputs that we have come to expect and depend on, that not only is the system we envision affordable, but that there are true ways to sustain it if we choose and advise around some certain specific directions that I think are within reach for California. So I think it will be an important conversation for us to listen to, but then also looking forward to the question and answers for Ken and the rest of us, and then the dialogue afterwards. So with that, Ken, if I could turn it over to you, and appreciate you taking time with us this morning.
Secretary Gali, members of the commission, thank you for inviting me to speak today. I'm going to discuss revenue needs and financial sustainability under unified financing. I'm going to start with a brief review of healthcare costs and financing under the baseline and projected changes over the next decade, and then discuss revenue needs and potential funding sources for year one, followed by a discussion of cost and revenue growth over a 10-year window. And as Secretary Gali indicated, these estimates are built on assumptions that align well with the aspirations and approaches the commission has discussed in its recent meetings. Next slide. So here are the main takeaways from my presentation in the spirit of not bearing the lead. If we continue our fragmented financing system, by 2031, health spending in California is projected to grow by $158 billion. That's in 2022 dollars. Under unified financing, we estimate that total health spending would be 51 to 88 billion less than under the current policy in 2031, with a cumulative savings of $300 to $500 billion over the 10-year window. Unified financing, as the commission has discussed, would make coverage universal and increase equity. And even so, the new revenues needed for unified financing would be less than employers and households would pay in premiums and out-of-pocket costs under the current system. The state has a variety of options for raising revenue that could be designed to be more progressive than our current methods of financing healthcare. Financing can be done in a way that is stable over time, but achieving financial stability will depend on controlling cost growth, which you'll be discussing today, and agreements with the federal government about the rate of growth of federal payments and whether or not there's shared savings. A reserve fund, which is accounted for in our cost estimates, would also allow the state to address short-term volatility in revenue sources and demand for health services. Next slide. So I'm going to start now with the baseline financing under existing policy. Next slide. We estimate that under the baseline, total health expenditures will be $517 billion in 2022. Of that, $222 billion, that's the green slice section, comes from employers and households. That includes $120 billion from employers and insurance premiums, including the health part of workers' compensation insurance, $30 billion in employees' share of job-based coverage premiums, $51 billion in out-of-pocket spending, and then that other section includes premiums in the individual market and Medigap policies. State and local government contributions to healthcare are included in the green slice because we treat them as part of workers' total compensation rather than as thinking of them as public funding. Next slide. So our current system of financing job-based coverage is regressive. I think you saw this this slide in a previous presentation. Those are income percentiles on the x-axis at the bottom and share of pre-tax income on the y-axis at the right. But if you assume that job-based health care is part of compensation and the cost of coverage is passed on to workers in the form of foregone wages, then those costs are effectively like a poll tax with equal costs regardless of income. So as Emmanuel Saez and Gabriel Zuckman note, for the middle class, health insurance is the largest tax they pay. Next slide. So when thinking about what would need to be done to replace spending on job-based coverage with unified financing, it's helpful to look at the share of payroll that employers and workers are currently spending on health insurance. Employer contributions are now about 10% of payroll in offering firms. And if we look at employer and employee contributions together, it's about 12.6%. Of course, this doesn't include out-of-pocket costs. Next slide. But this masks great differences by income level. Again, there's some debate among economists on who ultimately pays for job-based coverage and whether or not the entire cost is passed through to workers. But if we assume the full cost is passed through to workers, including the employer contribution, it comes to 30 to 40% of income for individuals at families at 200% of the federal poverty level. So if you look at the bar all the way on the left, that's for a single individual, earning $25,000 a year, about 32% of their income. And then for a family of four at 200% of the federal poverty level, it's about 40% of income. For those at 400% of the federal poverty level, it's again 16 to 20% for single and family, and 8 to 10% for those at 800% of the federal poverty level. But what's important here is even if we look at just the employee share of premium and out-of-pocket costs, those orange and green bars, it's still highly regressive and quite high for families at the lower end of the income spectrum. Next slide. By 2031, healthcare spending is projected to grow to $675 billion in 2022 dollars in California, with a $47 billion increase in employer and household spending and a $16 billion increase in state spending. Now, I do want to note here that this includes both increased health costs per person along with growth in population. And the main point here is to establish that baseline to compare to unified financing. Next slide. So I'll now turn to financing in year one. And we use 2022 for convenience in doing the estimates, not because we think you can start it that quickly. Next slide. So the spending estimates you'll see for unified financing are based on the analytic findings developed earlier in the process. And we know we've received various comments on those findings. Forecasting of this type, you should note, is not an exact science. It's certain that we didn't get everything right. And the final outcomes will depend on many of the policy details that you are discussing. But as a reminder, we assumed substantial savings related to administrative overhead, significant drug price reductions. We assume that provider payments in the aggregate are reduced by the estimated reduction in billing and insurance costs, but otherwise stay the same. If the state chooses to reduce payments below existing levels in year one, as some commissioners have suggested, then the savings would be greater. We also take into account increased use of services associated with expansion of coverage and reduction in consumer cost sharing. Funding of reserves and a just transition of displaced workers are in the model. We account for reduced aggregate health expenditure growth, which can be achieved by a variety of means, including payment reforms, systems of accountability, and as Professor Zhao has argued, which that can reduce waste and fraud, and care coordination. To the degree that we've underestimated savings, as some commissioners have suggested, that would be a welcome outcome, and the state would need to raise less revenue than we are projecting. If unified finance system doesn't take actions to control cost, then of course, more would be required. Next slide. So this slide compares financing in 2022 under the current system, the baseline that's on the left, and under unified financing on the right. And we estimate that the $222 billion, that's in green, in projected baseline employer and household spending would need to be replaced by $207 billion in new revenues under unified financing. And that's for a direct payment, a scenario with direct payment to providers and no out-of-pocket costs. Now, this assumes that the federal government contributes the same amount it otherwise would spend on Medicare, Medi-Cal, and home supportive services and Affordable Care Act premium tax credits in the baseline scenario. That's the blue portion. And the state and local governments contribute the amount they otherwise would spend on Medi-Cal and in-home supportive services. That's the I guess, lavender portion. And then other spending, such as public health and research spending, is not affected by the policy, which is in orange. Next slide. Now, the exact amount of revenues needed would depend on design options. So again, we've got the baseline scenario on the left. And again, we assume that existing federal, state, local, and other spending, those blue, lavender, and orange bars, stay the same across all of the scenarios. With progressively scaled cost sharing, so that insurance covers on average a little over 95% of cost, $20 billion would come from out-of-pocket costs, so and $168 billion would be needed to be raised in new revenues, or approximately $40 billion less than in the scenario with no cost sharing. If long-term services and supports are expanded under the no cost sharing option, then the needed revenue increases to $233 billion. And just as a note, for the reminder of this presentation, for simplicity's sake, I'm using as the base option unified financing with no cost sharing or long-term support and services expansion. That's not a policy preference. That's just a point of simplicity to be able to look at different comparisons. So next slide. So as presented before the commission last August, there are multiple ways that the state could raise the necessary revenue for a unified financing system. And I'm going to focus here on options with a large, stable tax base that could provide the core revenues for unified financing. And just note, these sources could be supplemented with a range of other complementary taxes that also can help meet additional objectives on equity and incentivizing positive health outcomes. But this slide gives you a sense of how much each tax could raise per 1% point tax on that base. And I'm also going to just run through some of the strengths and weaknesses of each. Starting with a payroll tax, it's fairly simple, can be straightforwardly substituted for our current system of job-based coverage. It'd be more progressive than our current system since the payments would be scaled to income. Chief drawback is that it's a tax on labor, which can distort the demand for labor versus capital. And if the state were to consider a payroll tax, I encourage an equal tax for independent contractors, which is not included in this estimate. So avoid creating incentives to skirt the employment relationship. Each 1% in payroll tax would raise about $14 billion. Next, we have a broad tax on labor and capital income along the lines proposed by Emmanuel Saez and Gabriel Zuckman in the context of national unified financing proposals. This would be a tax on compensation, corporate profits, unincorporated business income, and interest income. It's much more progressive than our current financing and has the major advantage of treating capital and labor equally. So there's no difference in tax rates related to how income is earned through compensation, profits, unincorporated business, et cetera. So there's no incentive to move income in one direction or another. My estimate here is based on what we achieved by building relatively straightforwardly on our current tax system. That means you don't fully account for business income, say you'd see in overall national accounts. That base could be broadened if the state wanted to change the way profits are currently accounted for, but that is obviously more complicated to do. With the way it's calculated here, each 1% on a broad tax would raise $19 billion. Gross receipts tax has the advantage of a very large and very stable tax base. The biggest drawback is that it taxes goods and services at every point along the supply chain, which creates a pyramiding effect as you go through each step in the supply chain. And that also means a big competitive advantage for firms that are vertically integrated. So there's fewer steps in those supply chains. Gross receipts taxes are also not sensitive to a firm's ability to pay, as would be, say, a tax on profits. For those reasons, existing gross receipts tax tend to be small in the sort of 1% or less range. And as some California cities do, the tax rate is varied by industry in order to take into account things like in a high volume, low margin industry, they have lower rates than in an industry, say, where you have a lower volume and higher margin. So if the state were to consider such a tax, it might want to consider exempting the first 2 million of income, which both leaves out the smallest businesses and vastly simplifies tax collection. Now, in terms of who ultimately pays, well, there's some variation by industry depending on whether or not you're competing with industries out of state. A gross receipts tax functions a lot like a sales tax. And most analysts view that the cost is passed on to consumers in the most part, and so is similarly to a sales tax is considered to be more regressive. Each 1% in a gross receipts tax raises about $47 billion. Another option with a broad base is extending the sales tax to selected services. And as with any consumption tax, it has the potential for being more regressive than other taxes we've discussed, though it's likely less regressive than our current sales tax on goods. Each 1% would raise about $9.5 billion. And as context, the current sales tax rate is 7.25% in California. And finally, the state could increase personal income tax. This $16 million is the amount that would be raised with a 1% point increase in income taxes. Now, of course, that could be done in ways that are more or less progressive. It could be done across the board, it could be done more progressively. For any tax that doesn't retain the value of the federal tax exclusion on employer-sponsored insurance, the state could try to seek a change in federal law that would allow it to recapture some of that revenue. Now, again, these taxes aren't exclusive, and you could put some of them, a mix of them together to get the full package. In doing so, you'd probably want to look at putting together options that don't tax the same base. So say a payroll tax or income tax could be combined with a gross receipts or sales tax, for example. Next slide. So in putting this together, it's important to think about the financial effects on lower income workers and families who currently are enrolled in Medi-Cal without any cost or covered California with a minimal cost. So if we have taxes where the incidence of the tax is going to fall on those families, that could mean an increase in their expenses. So the effects of new revenue streams on lower income families will depend on the incidence of those tax rates, of the taxes that replace employer and individual spending. Short-run impacts for workers with job-based coverage depends in part on whether or not the state mandates that employers pass through any savings to workers. Workers in low-income families, as noted, could see real wages or purchasing power erode over time if employers pass through cost of new taxes onto workers, or if producers raise the cost of goods that lower-income workers consume. But the positive news here, as Commissioner Comsty has noted, is that measures could be taken to mitigate any cost shift to lower-income families. Some kinds of rebates are a common feature of many of the unified financing proposals. Just to note that the cost of those measures or any rebates or breaks for lower income families or breaks for small businesses would need to be included in determining tax rates. Next slide. So all of our estimates here assume that the state establishes a reserve fund to address short-term fluctuations in revenue or spikes in demand for health services. Specifically, we assume that the state establishes a financial reserve fund of 10% of the state share of unified financing to cover fluctuations in revenue due to economic recessions. And looking back at the Great Recession and the dot-com bust, and 10% gets you where you would need to be in general. We also assume that during economic downturns, the federal government has tended to also increase the state matching funds, and that California would continue to gain from those increases. If you were to use revenue bases that are not as broad as the ones that I've mentioned that fluctuate more, then a larger financial reserve fund would be needed. For risk reserves, we assumed 5% to a little under 12% of claims, depending on the option. And to finance that, we assume that the state issues a $20 billion 30-year bond as a start, and then builds up the remaining reserve over the 10-year period. And the state could consider other financing options for the reserve as well, which we're happy to think about. Next slide. So now I'm going to turn to long-term financial stability. And again, for ease of comparison, all of our out-year projections are done in 2022 dollars. So next slide. So as we discussed earlier, we estimate that under current policy, health expenditures in California would increase to $675 billion by 2031 in current dollars, and that's the gray line. Under unified financing with no cost sharing and no long-term service expansion, if cost growth is kept to 0.5% below national health expenditures, total health expenditures would be $51 billion below the baseline in 2031 for a cumulative savings of $323 billion over the decade, and that's the blue line there. And if cost growth can be kept to the rate of growth of the rest of the economy, to GDP, spending would be $88 billion below the baseline for a cumulative savings of nearly $500 billion over the decade, and that's, we can see in the orange line. Think of that $500 billion would be the space all along there between the orange and the gray lines. Next slide. So as shown in the prior slide, one major factor that will affect financial stability is annual health spending growth. And to put this in context, over the last 2 decades, health spending has grown an average of 1.5% over GDP. It's been slower in the last decade, and it's expected to grow about 1.3% over GDP in the coming 10 years, in the next 10 years. The second factor is the extent to which the federal government will agree to share some of their savings with the state. And I know that that topic was discussed in part in your September 23rd discussion. And we'll see how that impact on the next slide. So next slide, please. So in this slide, we look at 4 scenarios combining cost growth with whether or not the state captures the savings to the federal government. So if you assume the state captures half the savings, it'd be the midpoint between those relevant estimates. So the dotted line here shows projected revenues of $242 billion in 2022 dollars in 2031. And we assume that each of the revenue options presented above on those broad bases will grow approximately at the rate of the economy as a whole. So the 242 billion is reached by growing our year one revenue estimates of $207 billion at the rate of the projected growth of national GDP from 2023 through 2031. As with any long-term projections, these estimates are subject to considerable uncertainty. If the state were, so in that context, if the state is able to capture all the savings and keeps cost growth to GDP, that's the column on the left, there'd be a substantial surplus by 2031. And if that can be done, among the many options for the state at that point would be to reduce tax rates, increase investments in addressing social determinants of health, and or build a more robust reserve fund. If cost growth is kept to national health expenditures minus 0.5 percentage point, and the state captures all of the savings, or all the federal savings, or if growth is kept at GDP and the state doesn't share in any of the federal savings, we'd still anticipate a surplus in year 10. And that's a surplus of about, works out to about 8 or 9, about 8.5% over the base that you're raising the revenue for. If the state keeps cost growth at national health expenditures minus 0.5 percentage point and is not able to share in any federal savings, so that's sort of our worst case scenario here, we project revenues would still grow at a rate to meet expenses, or at least slightly more than expenses. But as you can see, there's a lot less room for error. And so if costs go up are a little higher or economic growth is a little slower, then you could end up in the red. And that scenario really highlights the need to focus on keeping cost growth below current projections. Next slide. So in conclusion, we find that unified financing can meet the ambitious and important goals of expanding coverage for all, improving equity, care quality, and affordability, while bringing significant cost savings to the people of California over time. There are various options to raise revenue with different positives and negatives that can be combined in different ways. But in developing the revenue package, it's going to be important to pay attention to the distributional effects and think about steps to mitigate any of those effects through things like tax rebates or excluding certain income from taxation. Finally, stability in tax rates can be achieved for a unified financing system in California, but that's going to depend on controlling cost growth and on agreement with the federal government about the rate of growth of federal payments. An important part of that question is whether or not California can work out an agreement over shared savings to the federal government. Thank you.
Ken, thank you so much. Commissioners, I had intended to go directly into slide 29, but I think this was such an important set of slides that Ken, you presented. I want to give the commissioners, if you have time to stick around, Ken, 20 or 30 minutes before we delve into our next couple of connected conversations, to really ask you some questions about the assumptions, about what you presented in general. So I just wanted to open it up. But before taking commissioner questions, I'll also just say I think it's another really important takeaway that we're spending a lot now on healthcare, and it's going to grow fairly significantly, and that the tools that we have available to us currently are maybe insufficient to really prepare us for what comes over the next decade, and the need to really consider what other tools might be available as part of our next conversation on cost containment and helping slow cost growth. I think it will be very important. And then I think a number of questions come to my mind, Ken, around how we make sure you're presenting certainly sort of the middle case scenarios, or the scenario of experience for many Californians in the middle, but how about those who might end up paying more than they pay today? Or how do we encourage and work with employers who may be concerned about how they sort of experience this new system, whether it's on the taxation piece or some of the other areas around choice and other attributes of the healthcare delivery system that I think will be important for us as a commission to consider and get your thoughts on. But before you answer my couple of questions, I see a number of hands up. I'm going to go in the order that I saw them come up. But if we can start with Jim Wood. Jim, I know you're off camera, but hopefully you can unmute easily and certainly share your thoughts or questions for Ken.
Well, first of all, I just want to say thank you, Ken. That was a fabulous presentation, and I really appreciate the information you put out there. I think it shows there's definitely a pathway here, and that's encouraging. I have some questions, and I'm going to run through them. There, I think they'll be quick to answer, so I don't want to hog a lot of time here. But you mentioned with regards to the reserve fund, when we got into the Great Recession, the state cut a lot of programs and provider rates. Did you consider that when you were looking at the reserve? Because that's what we had to do at the state level, and a lot of programs have not been fully refunded, even though we're now 10 years past that date.
So we were looking at what the size of reserve fund that would be needed to avoid any of those kinds of cuts.
Okay.
So we looked at what had happened in previous recessions with those kind of more broad-based revenue streams. And again, with some assumptions here that the federal government, which of course has raised matching rates for Medi-Cal and all during recessions, that pattern would continue in the future.
Okay. And then drug prices, you talk about reduction in the cost of drugs. Obviously, we're struggling. A lot of that is at the federal level. We've seen how that bogged down in the discussions over is still bogged down. How do you see drug prices getting reduced in California? Is that because of the state's ability to bargain like we do with Medi-Cal? Or what are you seeing there? Because that has vexed us. We try really hard on a lot of levels to try to reduce the price of drugs and have really not had the success we'd like.
Well, overall, the key point here would be that the state would be the sole purchaser of drugs for California, and so would have tremendous bargaining leverage, which doesn't exist today. Now, note on the federal level, much could be done, but the politics have not always have not been there in terms of having the will to do so. But with the state leverage to be able to be that sole purchaser, I think there is a real power to bring those costs down.
And then something to think about, and I'll go to the last question, but as we start to see inflation and reared its head in the last couple of weeks, significant amount of inflation. I'm assuming that there's been some thought to what happens if we see rampant inflation in general. I mean, price of gas has gone up, groceries are going up, electricity is really high. What do we see, and how does this affect our ability to finance healthcare?
In general, in an inflationary period, we'd expect also the bases that make up those revenue streams to grow at around the same pace. So I wouldn't expect so overall, I'd say just as a note, the inflation we're facing right now is primarily a supply chain problem. And we know that if there was any kind of longer term inflation that was not based on those kinds of specific considerations, we'd expect the Federal Reserve to act and to tamp it down as has happened more in the past. So I'm sort of less worried about long-term inflation, but overall, again, we'd expect the economy to grow, at least those revenue streams to grow along with inflation.
Great. Thank you very much. Appreciate it. Thanks.
Thanks, Jim. Rupa, you're next, and then I see Richard and then Jenny following. But Richard, Pam, that was. So Rupa, take it away.
Thank you. Ken, thank you so much for that great presentation. That was very helpful to see things broken down like that. I've been very interested in I want to talk about two things. First of all, the intersection between industries and health. So in California, we've had whopping success with the public smoking ban, which took about 20 years to enact, but saved over 1 million lives in California and greater than $134 billion. So looking at how industries in California negatively impact health, right now those costs are being carried privately on families. So for example, I live in East Oakland where the ABNI foundry is permitted to pollute the air with hexavalent chromium in our neighborhoods that disproportionately impacts, people in the lowlands of Oakland with Alzheimer's, asthma, COPD, cancer, and that those costs are carried by the people and that pollution is green lighted by the state. So speaking with Jared Blumenfeld at Cal EPA, speaking with the US EPA, so from the city, county, state, and federal government, the inability to control those industries that directly impact human health. It just makes me think of if California was really tied to the financing, the state was tied to paying for people's healthcare, perhaps it would get more proactive in preventing these kinds of toxic exposures that disproportionately impact Black, brown, and poor people. For example, what would a pesticide ban look like in California that would also improve the health of our farm workers, the health of our soils, which right now are aerosolized. The valley is a dust bowl, which is causing problems with cocci and all the things that we see. So I just wonder about tying those things, if there's a way to model how some of those industries are impacting, driving up healthcare costs, and how curbing some of those industries and controlling them might actually give us some benefits using some of the modeling that's come out of the success of the tobacco ban. So I don't know if that's something you could do for us, but I would love to see that. And then looking at the healthcare costs of racialized groups from 2003 to 2006, there was a great study that showed that the combined costs of health inequities and premature deaths in the US in that time period was $1.24 trillion. This is in 2008 dollars. And eliminating those health disparities through enacting policies at the state level that echo the Black New Deal, the Green New Deal, the Red New Deal, these things that actually target the exposome of toxicities that are driving the chronic inflammation that we are seeing as health workers on the front line. So I'm just wondering if there could be modeling in your work that could look at what some of those structural changes might look like, including single payer. So, if we don't, this is a major part of eliminating health disparities so that people have full access to the wide suite of availabilities in our healthcare system. The last thing I want to say is I don't know if you all saw this article that just came out in the Atlantic, but it should put us all on guard. Because the economic modeling that we're doing right now, this is by Ed Yong, and he's talking about the mass exodus of healthcare workers in our healthcare system in the United States, basically saying that our healthcare outcomes, the quality of care that Americans are going to get in the United States over the next 5 to 10 years is going to be dismal. At UCSF this July, 30 ICU nurses, our best, most seasoned nurses, walked off the job because our healthcare response during this pandemic has been guided by corporatist interest, healthcare executive interests, and not the safety of patients, and definitely not the safety of providers. And so with this hemorrhaging, so 18% of our healthcare workers have left, and many of those have been our most seasoned workers. What is that going to look like in terms of costs? Like how to estimate in your modeling what is going to happen, to those of us who are staying behind and continuing to work, and how can we help, mitigate the extraction of resources from the healthcare system to, let's say, the private shareholders of private healthcare insurance. So what are the ways we can safeguard that funding staying inside the system so that we can actually improve safety for patients, healthcare outcomes for patients, and safety of providers? Thank you so much.
I'll just thank you for that. I'll just note that, and I mean, that was an important reminder that many of the social determinants of health are not things that are contained within the healthcare system. And that I think, as you note, if the state now is overall responsible for health, that in terms of internalizing that could create greater incentive for the state to really address some of these broader issues. But those broader issues need to be addressed in whichever way the state chooses to go here. So to get to health equity requires both a equity within our healthcare system and brought across affordability within our healthcare system for everyone and access, but it also requires going beyond what's directly in the
Yes,
healthcare system.
and that's what I'm trying to get at here, is that we've atomized and separated and dissected these things apart, where the public smoking ban shows us that when we don't atomize it, when we realize that industry is directly impacting health and the state makes bold movements to curb those toxic exposures, we get a win-win-win. And so how can we encourage our economic modelers to start looking more wholly, and for the state of California to take on a role as a health a health envisioner for all people of California? And that's really what this push for single payer allows us to start imagining. So that's why it's so exciting to me. Thank you so much.
And just on the question of workforce, I mean, again, that is not something that we are able to model in this, but workforce will be an important question, whether there's a unified financing system or we continue in our current direction, and that is an area that needs attention.
Yeah, before Richard Pan jumps in, Rupa, thank you for the comments, and Ken, your response. I think one of the things, and when you see and dig into the survey results, I think this is going to be one of the things areas of grappling for the commission. There is around social drivers of health, some of the, I think a real focus of the state of California right now is just the intersection between climate, equity, and health, and bringing these areas together. So Rupa, to your point, I think there is a lot of increasing movement that is coming from not just within, but outside of the healthcare system, and tying it slightly together. It's always slower than any of us would like, but I'm myself starting to see a lot of the movement that I think we'd be proud of down the road. And then the issue of the workforce, I have to say, just a point of privilege that my opportunity to engage with all sectors of California's healthcare delivery system and social safety net system, that we do have a looming workforce challenge and crisis. And I would say opportunity, that many of the areas where we see workforce needing transformation, whether it's in where they work, how they work, who's doing the work, what kind of work is being done. I think we have this real opportunity right now in California, frankly, nationally, to see the crisis that looms as an opportunity to really fill in some of those holes in the workforce that even when we were robustly staffed, we saw them around areas of inequities, distribution, who was doing what, et cetera. So I think there's a tremendous chance on that as well. So Richard, I want to get to your questions as well.
Thank you. And I understand that the opportunity for actually commissioner comments comes later. So I'm going to try to stick to questions. And again, thank you, Mr. Jacobs, for your presentation. I had a few questions sort of following up on actually also my good friend, Chair Assemblymember Woods. So first of all, in terms of sort of projections of healthcare costs, obviously a lot of different factors. For example, aging population. So even the same population that's getting older, so it's higher demand. But one specific one I wanted to ask you to address is what I'll call Baumol's cost disease, right? So we know labor costs for services are going to rise faster than for manufacturing and other things. And so it tends to rise disproportionately. And I'm proud to be a member of a union. It AFSCME. I know many of my brothers and sisters are now on the picket line or have recently been on the picket line. We've also heard from another commissioner about the fall and the reduction in people leaving the health professions. So I guess first question is that as we're looking at the healthcare costs, obviously there's some potential savings for unified financing, but the baseline, whether we do, whatever, in terms of labor costs, and being sure that we, are providing the kind of, pay and benefits for the people who are working in the healthcare workforce. How do you see that factor in terms of the future of cost of healthcare going forward? So we know that, so we have baseline bond mills cost disease. We have, underpayment. We talked about cuts that haven't happened in recession. We also know that increasing technology tends to require more education for the people who are actually in healthcare as well. So there's a labor issue there. Can you just speak to that in terms of your projections, especially as you're projecting out into the future, like 10 years, how we should incorporate that to be sure that workers are being paid justly?
I think that those are, thank you for those questions. The overall, our cost projections are based on the CMS's projections for national health expenditures. So to the degree that they have incorporated those factors, then they're included, and to the degree that they've underestimated, they're not. I will note that in recent years, healthcare has been growing. The last decade has been growing much more slowly. Part of that's after implementation of the Affordable Care Act. They're projecting it for it to increase to look more like it has done previously. So whether or not they got all those factors right, I think is a reasonable question. But it also will be important in thinking about the systems going forward and in reimbursement systems to be taking into account those kinds of workforce issues and concerns to make sure that we have a stable, well-trained workforce in an ongoing manner. So that is an important consideration that needs to be factored into how all those policies are put together.
Okay, I appreciate that, because the rise in cost of labor in healthcare may be faster than the GDP growth will be. And so far, I haven't heard anyone said we need fewer people. I keep hearing people saying we need more people in healthcare. No one's telling me there's a shortage, there's a surplus. Actually, I'm more likely to say there's a surplus than most of my colleagues are. So I want to be sure to incorporate that. Second question is that I would make note the slide you have, I think on my thing, it's page 20. When you're looking at unified financing, no cost sharing, I guess the question I have there is, if we don't have cost sharing, and believe me, I'd love not to have cost sharing. We know the RAND insurance study showed that there's a significant increase in utilization. I guess you could say utilization, but we'll just cut everyone's reimbursement. So therefore will be no net increase. But that doesn't seem to be reflected in your slide. That increase, 20% increase in utilization hospitalizations, what came out of the RAND insurance study, which is one of the more expensive factors. So can you just speak to how you incorporated those, your projections, how you corrected for that, or incorporated the findings from this very important study into projections when it comes to cost sharing and other types of, in your modeling?
Yes, thank you, Senator Pan. So in that no cost sharing model, we do project increases both from more people having coverage, and if cost sharing is eliminated, we project increases in utilization. The reason that still comes out lower than the baseline is because we also have a bunch of other savings, both in terms of billing and insurance costs, administrative costs, and pharmaceutical costs, et cetera. So that is in the baseline. And you can see that if you compare that to the next bar over, which is the with cost sharing. There, the costs go down by $20 billion. And that is cost sharing that's at 95% AV, or 95.3, I think it averages out to. That assumes no cost sharing for those in the under 200% of the federal poverty level, and then scaled up a little, and then like something closer to job-based coverage at the top. And so there you can see the whole system is $20 billion less. And that model still has some increased utilization because of cost, due to less cost sharing. So that is fully factored in the model.
Okay. All right, that's helpful to know. And then I guess the other question I have is that, appreciate the projections and the modeling. We know models have assumptions. They're not necessarily, always going to hit the mark. For example, if this is 2022, we know that as much as we don't like all the overhead, we have a bunch of people working in billing departments that we're probably not going to fire en masse and say you're on your own now, et cetera. Even if over time, hopefully we can reduce that overhead. And you did talk about workforce transition. So given the uncertainties, would you say that when we also say healthcare is a right, would you say that we should do this? And you talked about reserves, but shouldn't healthcare be an entitlement? Medi-Cal is an entitlement, so therefore not subject to ordinary budgetary pressures. So basically government's obligated to pay whatever it actually ended up costing in the end. So that like we do with Medicare and Medicaid. So the state, if we do set a unified financing, it does need to, if we're truly going to say healthcare is a right, it needs to be an entitlement that, certainly we will put in the policies we need, but we're not going to simply say, well, the money ran out in May, so suddenly now everything's closed, or everything but the ER is closed. And that we'll just have to roll it over into the budget and then work out the next year. So I just wanted maybe a comment about the nature of the financing mechanism, and also recognizing that it shouldn't be a block grant, it's an entitlement like Medicaid currently is and others.
I think this gets to the discussion that you're going to be having a little bit later this morning around governance, because those really are some of the key questions. I mean, one assumes that this would be a separate pot of money from the state budget that would have a governance body overall making those decisions. But that's why it is so important both to have a broad enough base on that financing so we don't see large fluctuations. And that's why we suggested a set of revenue streams that would have that broad base and have less have less fluctuations. But also note that the governing body would have multiple parameters on which to make decisions. So if there is a point where revenues are growing not as fast as health costs, then there's a set of things about what do you want to do? Is there more that you can or will do to control health costs? So then other measures in that direction could be considered. Then there is questions could be raised about some pieces of services. One would hope you avoid that discussion, but in some cases where there are services that aren't providing high value, say, and really focusing on getting high value services and reducing low value services, that's a direction that you can go in. Or, I think what's so heartening, what was interesting to me, and I didn't expect this fully, I have to say, when we did all those scenarios in the out years, I had expected some of those to go into the red, was that to the degree that there is some room here, but there will be time to figure these things out. And as you see the trajectory growing, especially if there's a healthy reserve, then you've got time to make decisions. And if that means there's a very small increase in tax rates at some point, that's another direction you could go. So I don't think it's determined at the beginning as to what those choices would be, but just note all of those choices are ones that are being made right now in this current world. Costs are going up, and the result of that cost going up are people are paying more, or there's some kind of rationing going on to the degree that people can't afford healthcare. And so here we're talking about mechanisms to control those costs and make those decisions in a way that have greater equity and go much farther in terms of promoting value of care.
And I appreciate that. So, Jen,
Yeah, and let me just wrap up here. I appreciate that answer. I too, well, actually, I was there in the Great Recession. I think it was before Jim Wood actually got into office, where we were asked to vote to cap the number of Medi-Cal visits to 10 visits for every Medi-Cal patient. That was the solution to try to address our budget deficit. So, I think we need to keep that in mind. Of course, we had COVID. Fortunately, we are in more of a, we're starting to recover economically. Point out that GDP went down while our healthcare needs went up. So again, tying the two together doesn't always make sense. And obviously, COVID itself has, it's driving some healthcare costs, and we'll see about long COVID. I also point out, since it was brought up in terms of externalities, at least nationally, it's been estimated we are incurring $3 billion in additional healthcare costs because people aren't getting vaccinated. Yet you could see the challenges, and as someone who's in the legislature trying to put in rules to get people vaccinated. And we know there are not only at the state level, but we know locally, and even the local governments, even here in California, that have actively resisted public health measures to stop the spread of this virus that is actually not only, of course, killing people, but is also increasing our healthcare costs. So there are some limits to what we can do, even as a state government, to get people to behave in ways that actually that basically spreads costs not only to themselves, but to other people. Thank you, and I look forward to our further discussion.
Yeah, so Richard, thanks for the comments. And as you said, let's use the next 10 minutes to focus on questions rather than comments, so we can get to the comments as well. But we're going to spend about 10 more minutes on questions, and then I'm happy to move into the conversation part of this as well. And those who haven't had a chance to make some ask questions and comments, we'll get to those as well. So Jenny and Richard, then Carmen, and then Ken, love for you to stick around. I'm sure there'll be more comments, but we'll move into our next set of slides. Jenny, go ahead.
Thank you. Again, I add my thanks, Ken, for this incredible body of work that you've presented us with. My one question is related to the bar, slide 20, and the last bar, which includes this unified financing, no cost sharing with long-term services and supports expansion. And I raise that because I know that for illustrative purposes, you said, let's just do the straight on one without LTSS. And the reason I raise this is my concern is that I think it needs to be much more baked in as a scenario, because the issues of chronicity and multiple conditions, and I've been spending, frankly, more time in the depths of dementia and Alzheimer's disease, and as the population grows and ages, this issue is a big under the iceberg factor of where cost will go, let alone workforce and all. And I just wonder how that gets factored in, because this is something I think we cannot isolate as a separate piece. It's part and parcel of population health and chronicity. So I just wonder, because I think there are tremendous hidden costs, but they're felt by people who have multiple morbidities now. How does that show up in our modeling?
So that's a great question, and I think that is right in terms of effect, the effect around having the long-term services and supports overall on health. Just a quick note on the modeling, which we didn't show here, that comes out of the analytic model, is even with including LTSS and no cost sharing, so the sort of that end of it, by the end of the 10-year period, with cost savings 0.5% below national health expenditures or down or at GDP, the overall cost is still lower than the baseline under our current scenario. And it starts out a little bit higher because putting in long-term services supports is an investment up front, but depending on how well costs are controlled, we have by the 2nd to the 5th year costs going below the baseline. So that is just to give some picture there.
Thank you. This is an area that I frankly, and I think if you're using baseline as if nothing changed, of course, but frankly, this whole aspect has to have perhaps creative ways to think about the force multiplier of this issue. Thank you.
Debbie, I'll just, as we move on, this has been one of the areas, especially having reviewed Ken's presentation, figuring out how in the next meeting or a couple meetings, we spend a little bit more time on exactly what you're talking about. So I hope we'll have a chance to. So thanks for flagging it. Richard Scheffler, then Carmen.
Ken, great job. Proud of you being from Berkeley. Go Bears. Let's beat Stanford this afternoon. That would be even better. I have a couple of questions for you. I suspect you know that the healthcare system in California is 60% integrated capitated plans, at least 60 and growing. And for the most part, they have little or no co-payments at all. And I'm just curious which healthcare system you're actually modeling. So that would be one question. We're not supposed to have a discussion. And then the second question I have is, I think you're probably familiar with Prop 63. This is a tax on millionaires that was passed in 2004 for mental health. It's a 1% tax on their income over $1 million. It was thought then that all these millionaires would move to Texas, but it didn't happen. And of course, there's been various maturations about what was done with the money. But another financing scheme would be, instead of $1 million, 500,000, 250,000, whatever one likes, because there's a precedent for this. It's on the books, and it's often easier to use a mechanism that has some history in the state. So at some point, I would like you to comment about that. The other tax that's frequently used, and I'm sure you know this, is an excess profits tax. There are parts of the state where, because of market power consolidation, both the hospitals and other providers make huge profits. And if you want the data, I'd be happy to send it to you, but it's readily available and well known. Some states, I think from memory, Minnesota, actually do something about those excess profits and use it for financing the system. So I have others, but I thought I'd be polite and stop at 3. So there you go.
So just quickly, the modeling was done on the in California, taking into account what the current capitation, the current part of the market that's capitated and current actuarial values. And just say job-based coverage, the average actuarial value of it is around 85%, might be off by a couple of percent points. So when we're looking at reducing the no cost sharing is bringing that 85 up to 100% paid for by the system. And the partial cost sharing is bringing that up to 95% paid for by the system. So this is based on the mix in California and California data. On the issue of the millionaires tax, just as a note, you are correct that the taxes heretofore on millionaires have not led to an exodus from the state. Part of this is in thinking about what are the bases that are broad enough to raise both the amount of revenue with the kind of stability. So if you look just at millionaires on the estimate I gave for income tax, 1% is about 1/5 of the total. So you can do the math as to where you would need to be to get to the kind of money that we're talking about.
Yeah,
and
so
then there is.
You could start with 500,000. You don't have to start with $1 million.
Right, but yes. So and you could look at where each of those breakpoints, and you could do it all progressively.
That's right.
That is correct.
So
And-
I would suggest you add that to your report at some point. Take a careful look at the revenues, who pays them, and the fact that it's had no noticeable effect on people moving to Texas or wherever they move to. And I do think it's a viable option, even if it doesn't, come up with a total amount that would be a significant amount. And the excess profits tax would get us a huge amount of revenues along those ways, because what you haven't looked at, and I think you know that, is the incidence of this across the state. There's huge variations on what would happen and who would benefit from this and who would make more money. And there's a lot of inequities in the system already that I know you know about. I know about because I study market concentration. And so, I think some differential policy on taxes using an excess profits line of reasoning might be fruitful. So I just passed that on to you.
Appreciate it.
Thanks, Richard. And Carmen, last comment, last set of questions before we get into commissioner comments and go into another part of the discussion.
Yeah, so, thanks, Ken, for the work that you've done on the modeling. I know I've given you a lot to consider with all my comments, and I'm glad you've taken a lot of it into account. I want to, kind of to echo what Richard was saying. I do think we can put together, and we should put together, really, really detailed options for the legislature and the governor on different revenue generation plans. I think it's really important because we're always getting caught up in this kind of quagmire of how are we going to pay for the amount of state revenue that is no longer going to be paid through ESI, through premiums and deductibles and copays. So I think it's very, very important that we have that in there, and to the extent of I like the idea of saying how much it is for 1% of all these different types of revenue generation types of measures. And I think it's really important to kind of really distill what the potential exemptions could be for each of them, as in terms of like being able to start this discussion about the tax or fee revenue that we might need to generate. And I think it's really important to our discussion. And a couple of other ones that I want to point out, I think that I pointed out before, there's the potential for ending corporate tax exemptions, which, could be tens of millions of dollars from what the California Budget and Policy Center has put together before, ending charity care tax breaks, if I think that's really important. We can't be double subsidizing nonprofit hospitals, and there's also the idea of where we can redirect funds from other areas of the budget that there are ideas about reducing policing and incarceration state funds. Can we put those into healthcare? And as Rupert pointed out, what are the potential fees or taxes that we could put on polluters? So they're all really, really important things that we should put on the table. And then, kind of more generally, I want to make sure that, we don't get too caught up in this idea of like, what are the levers to reduce costs by reducing care? Because, as many of you've heard from the late Professor Uwe Reinhardt, it's the prices that are driving up healthcare costs. And I know, Professor Shao knows way much more than I do on this, but I think it's really important that we consider those mechanisms when we're talking about the financing, and how are we saving in terms of controlling the prices, eliminating the administrative waste, and what are the measures that we can put in, like and we've done this in AB 1400 and CalCare, where we say that reimbursements for providers go back towards care, that there are mechanisms, and we can talk about this later when we're talking about governance, but that we have mechanisms to tell providers through conditions of participation, through agreements with the state as the single plan that runs the program. The state as a procurer of healthcare can say, you have to show us, provider, that you're not lining your pockets, that you're actually going to reinvest that money into care. And I think that's a really important mechanism that we need to, make sure that we consider, and I know in my comments to Ken and Rick Kroenick, that I have a lot of ideas about how we can actually put that in economic modeling. And I think, we're really in a good place in terms of making sure that we can try to capture the savings in the financial modeling. And I guess my last point on the workforce question, and I think I really just want to reiterate what Rupa was saying, which is that, when we invest in our workforce, when we invest in the protection of nurses and doctors, when we invest in safe staffing, we get better care, and that overall helps us with the cost of care and making sure that people are we're not grinding away our workforce so that we have unsafe staffing and poor outcomes and higher costs and more need for acute care. And I think those things, I know it's hard to do that in financial modeling, but I think we have to keep that as a principle, is that it's not just a simple calculation of utilization and prices, because there's a lot of other mechanisms in there. If we literally kill our nurses by not protecting them, then we're going to have a worse healthcare system. And I think it's really, really important that we remember those things when we're talking about it. So I think, I'll save my other comments for later, but, I think those are kind of the things that are floating around from the discussion that Ken so generously put together for us.
Hey, Ken, I know a lot of comments, not only questions, but thank you for being part of it, and hopefully you can stick around. I want to get, just watching the clock, we have about 90 minutes before we really need to get into public comment. So we have two parts of a discussion that I want to just have commissioners, and Ken, hopefully you can jump in as well. If we can get Karen the slide back on, I think it's slide 29. Thank you. Yes, all right, slide 30. So we talked a little bit about how important it is in Ken's presentation to help contain the cost of healthcare and its growth. And I wanted to open up a conversation. I'll try to keep tight time on it for about 45 minutes around what we might do under unified financing to ensure that we're reducing the healthcare cost growth, that we're able to sustain some of the models that Ken just walked us through. I know there's a few examples here on this slide. These are not, of course, meant to be comprehensive. They're not even meant to be the ones that the commission thinks about or endorses. I know a number of you have spent time thinking about some of these specific areas. So I wanted to open it up to comments from the commission. Feel free, if you're not deeply engaged in any one of these topics, to ask some of the questions that might come to mind as we grapple with this issue. I might turn initially to Jim Wood and then Bill Shao to talk a little bit. Jim, you just on kind of the work you've been doing around healthcare expenditures and targets, and then Bill around some of the questions, concerns I know we've raised around fraud and abuse. in specific, but then really open it up to the rest of the commission as well. Jim, do you mind going first?
No, and thank you very much. I appreciate it. And I'm looking at the list here, and a lot of these things that are listed here actually are really significant. I would say that number one on things that I think are important are setting targets. Massachusetts has done that. What they didn't do was set enforceable targets. And it's not meant as a process to limit care in any way. It's meant as a way to try to make providers, in this case hospitals, in particular around budgets, more cognizant of waste and not just ordering tests or doing things that produce what we're concerned about low value care just because they can. And so it's important that if we're going to look at that there are targets, that they are enforceable, and that entities have an opportunity to weigh in and say, yeah, that was high because we blew past our target because we invested more in primary care. Great, that would be a really good reason for going through a target. And I would expect that these going to be different in different parts of the state. And that kind of ties with the aggregate hospital budgets. But I think it should be extended to all sectors of healthcare, not just hospitals. Their providers and doctors provide care as well. Medical groups provide care, and so people need to be, good stewards of public dollars, and care for the patient should be first and foremost, not ways to protect income, but care should be the first and foremost. But I think that one of the challenges for us as we get to how do we even establish those is going to come through our ability to analyze data. And one of those pieces of the puzzle is the all payer claims database that will actually come online here in about a little over a year, which will help us to be able to understand where are our health dollars spent and what kinds of outcomes are we potentially getting for the expenditure of those health dollars. I got spoken in one previous commission hearing about why is it that in San Diego County, and this was, I think this came from the California Healthcare Foundation. If it didn't, I apologize. But why is it that in San Diego County, in general, you can get costs that's care that is 20% less expensive than in Shasta County? And by the way, better outcomes. So what are they doing in San Diego County that Shasta County can be learning about and to better provide care for people in those communities? So I think I asked a question about drug prices earlier because that is something that I've worked on a lot over the years and has been really, really frustrating. I want to give kudos to Governor Newsom and his team for the idea that we could actually produce drugs here in California. Specifically around the one that would be the top of the list for me would be insulin. Why is it that over 100 years has passed since insulin was invented, and we're still struggling with the price of insulin out there? Because drug companies can charge a lot for it, and we need to rein that in, quite frankly. Diabetes alone accounts for a huge amount of expenditure through our state Medi-Cal system, about $3 billion in healthcare related expenses for people who have diabetes. Now, it's not all diabetes related, but there are other conditions that go along with diabetes that surface. So, and then I guess the final thing for me here, and I could go on and on here, I don't want to because I think it's more valuable to hear from everybody, is the value of prevention and especially in preventing diabetes-related disease and heart disease, a variety of different things. We just don't spend enough on prevention. So we spend a tremendous amount on care, but not enough on prevention. And I believe that in a lot of other countries that have unified publicly financed systems, they spend a lot on prevention. I marveled recently, I don't know if you read this or not, but 96% of all adults in Portugal are fully vaccinated against COVID. Think about that. They recognize through their system, which they have a publicly financed system, the value of the vaccine in a way that seems to cross political ideologies or personal ideologies for the greater good. And I just that is a tremendous preventive measure, and I think I would like to see more of those kinds of preventive measures that are available to people in California. So I'll stop there. I'll be very anxious to hear what others have to say.
Thanks, Jim. And I'll just also take a minute. I think some of the comments Rupa made earlier when she was speaking certainly addressed just the overall improvements of health of Californians and how important that is, and to keep our eye on not just using the healthcare infrastructure to make some of those changes. I think California has done a lot in this space, but can certainly do more. Again, many of the areas I think you mentioned, Rupa, that impact Alameda, Oakland, there's areas with similar sets of pressures and concerns across the state. So there's, I think, a tremendous chance to think creatively and importantly, not just through the unified financing system, but to address using other levers the health of Californians, and not just with an eye at reducing the demand for care, but reducing the type of care people are required to access, because hopefully their health is better overall. Bill, I
add one
on you as well.
Can I add one other thing, Mark? I'm sorry. Just super
sure.
brief.
Quick.
I apologize.
Yeah.
And that's just the value of a robust health information exchange system. And that's something that Bill Schauer talked about with Taiwan. But if we can't have robust health information exchange, we can't provide the best quality care, the most timely care, the most efficient care possible in California.
And when you see the survey results, Bill, you were good to succinctly say it's not just comprehensive, but it's a uniform one as well. So I think, Bill, I'll let you speak for yourself on this, but your comments in the survey, I think, are important in this regard too. But Bill, I'll pick on you next. Go anywhere you'd like, but I know thoughts on fraud and abuse, I think, are important to hear some of your ideas.
Thank you. Before I address the issue about fraud and abuse in claims, let me add something to what Jim said about the importance of setting total state expenditure targets. If we want a sustainable unified financing system, I think the international experience as well as Massachusetts have shown you have to actually have agreement on what's our expenditure in total for next year. Then you work out the details, what level by level, including on the payment methods as well as the rates or the global budget for hospitals. I'd like to point out that in that regard, Taiwan does it, Japan does it, Germany does it, England does it, and Canada does it. So as well as Massachusetts, and I'm sure you know, right now more than 20 states in the United States are all considering setting up an aggregate health expenditure budget prospectively. So I cannot, the question then, I don't want to take up your time, is how do you do it? Who is involved to setting that target? And that I can leave to another day about the experience of other countries or Massachusetts. Now let me turn to then fraud and abuse. I wrote a memorandum and then that was circulated to sent to all the commissioners. I was taking this from an academic point of view to first define what is fraud and what is abuse. I will not try to go into the details, but give you the magnitude for United States, that from all the empirical studies, there's at least 8 to close to 15% of our health expenditures spent on fraud and abuse. That, of course, is a conclusion coming from partial studies or from what FBI said. FBI gave a wide range of 3 to 10% of Medicare spending went for fraud. That's based on legal definitions and also what FBI able to investigate. A great deal of fraud, as what Gawanda documented in an article in New Yorker earlier about just abusing home care services in Texas. There are many documentation of that. And I like to see what the excellent job Ken Jacobs have done to include estimation what a unified financing scheme can reduce fraud and abuse. Now here, let me tell you how that's done. You need a unified clinical record system from which you derive a uniform claim system. United States doesn't have that now, nor does California. Once you have a unified clinical and claim system, you can identify which provider may be doing things which is really being outliers. There might be justification or good reason for it, but there's also could be true fraud or abuse. If you're interested, the first country has done that was an article published in 1975 in Ontario, Canada. Once Ontario, Canada developed a unified record system, they found some physicians are making claims as such volume, he or she must be working 24 hours a day, 7 days a week. When Taiwan developed that uniform record system, they found the same thing. And Germany did too. Let me just say, not all providers are committing fraud abuse. Usually it's less than 12% of the providers may actually doing this. So you actually build up the trust and reputation of the other 85% of the providers. Right now in the United States, we do not have such a system. So if unified financing system takes seriously to address the issue of 8% or more of our expenditures due to fraud and abusing claims, we can really have more funds to address the needs of healthcare, as to already bring out. How do we deal with the workforces, which is in shortage? Jim Wood did not even talk about the shortage in his district. We need money to build up maybe community centers first. And that needs money. The money, we do not want to actually encourage people who actually commit fraud or abusing the claim system. So that's, my argument is other countries show how a unified finance system could do it. And definitely with the big data nowadays, as well as artificial intelligence, the United States or California can do it even better. And I like to see the commission take this seriously, this issue seriously in the cost and the financing of the unified financing proposal we're taking. And when we do that, we do not have to reduce the price on hospital budgets. Let me make clear. To me, that's a non-starter. If a unified financing go in and say, we're going to reduce your revenue, you will have the providers, doctors, hospitals, nursing homes, testing labs, everybody going to be organized to oppose any legislation for unified finance. So we have to think ingeniously, constructively, realistically, how do we actually remove the waste in our current system? That's the plea I'm making to the commission today. Thank you for giving me this opportunity, Mark.
Bill, thanks for sharing your view and the point, and think it's an important one that a lot of us think about, the idea that a plan that restricts the financial condition of some of the providers or facilities in the state is a tough one, but I think there's a number of moves to make sure that it is driven by value, focused on patients as the primary. I want to pull a few other people into the conversation. Antonia Hernandez, I'd love to sort of just pick on you next, if you don't mind. You're often a real pragmatic thinker on these issues. You self-proclaim yourself as not a healthcare expert, but I'm curious when you see what Ken presented today and this idea that we're on a road that's just going to keep going up in terms of what we pay for what we have today, and there might be a storyline for a better system that is more affordable to Californians. I'm curious sort of what your reactions are. And before I turn it to you, I'd love to pull in next Kara Desert as well, to get similar sort of your viewpoint, and especially you were speaking in the survey around reserves and the importance of reserves, just sort of what you think the hurdles might be as we try to move this part of the conversation forward. And then if it's okay, just tee up a couple more people. Sarah, Sarah Flox, very interested in getting your take on what the other levers are we might be smart to use in California to try to think about costs, especially as we grapple with the questions that prior commissioners raised around workforce. And I know just thinking about the future of how we not just take care of our workforce, but build the workforce in a strategic way. So in that order, Antonia, Kara, and then Sarah, if you don't mind.
Well, I have found the last half hour the most instructive for me. And that is because I've been listening and we finally got to an issue that I do understand, and that's infrastructure. And the current infrastructure of our healthcare system is totally dysfunctional. I mean, if you talk about the issue of fraud, I mean, that's a substantial part. If we talk about the fact that we don't have a unified medical claim record system where you can really capture, sort of the cost associated and eliminate part of the fraud. I think what Dr. Wood said about prevention and the social determinants, external factors that impact health. If we could, and then also setting targets and parameters, the issue of, sort of insulin and diabetes and those costs associated. I think that there's so much that can be done to put some sort of rationality into the infrastructure that would then eliminate some of the costs that we're incurring now. And then we can deal with the cost of the providing of the care. So to me, this discussion about what can be done to take away cost, not associated with the giving of medical care, but sustaining a system that doesn't work. So I would say that for me, the really important one, and I think that these are tough issues, but issues that can be done. I mean, the unified claims record system is really important. Just like right now, and it's not that easy. Right now, we put in our little telephone, our vaccination. It's no big thing. You show it when you go to a restaurant or wherever the heck. It's very simple. If we can do that, why can't we do that for the whole system? So I would say, even before we start thinking about the cost of providing medical care, we need more time to focus on eliminating costs that are related to the infrastructure of providing medical care. And that, to me, I think would reduce the cost of providing medical care to all of Californians.
Thank you. I knew you'd give us a bring home pragmatic approach. And I think there's a lot of energy around what are those tools that help us build infrastructure differently to help make care both more efficient and more patient-centered. So I think those are really important formative comments. Kara, can I turn to you? Similar sort of question. What's your reaction to Ken's presentation, and then also just specifically on reserves?
We are taking on a monster task of reimagining healthcare in California. And what's the bottom line? What reserve do we need to sustain this reimagination in our healthcare system? And what's the initial financing that we'll need to create it? And so, I know these are rough estimates. That's part of this great experiment. But understanding those numbers and the 30-year bond at $20 billion, I think is really helpful. It's where the rubber meets the road. And so really appreciated Ken's presentation and having a really direct conversation about financing and reserves. I'm optimistic that if the state is truly, the sole purchaser of drugs, and we have the opportunity to reduce waste and fraud, as we talked about, with unified financing, that there will be some pretty incredible savings. So I'm optimistic about that and appreciated that part of the discussion with the commissioners as well. Really want to shine a light and piggyback on Commissioner Ginny Chin Hansen's comments about long-term care. I was likewise disappointed that wasn't a part of the analysis included. I think it's incredibly important. We've talked in this commission about the LGBTQ community, and we have a Stonewall generation that doesn't have traditional families, who came out in the 50s and 60s and were ostracized from their families and don't have necessarily the familial support structures that our seniors need to access care. And so in the chosen family structure, it becomes really important to think about long-term care for that particular generation. So I think I support the proposition that long-term care needs to be included in how we think about really the reimagination of the healthcare system, but particularly the cost analysis. It is, of course, we know, very expensive to care for folks in their last years, and it seems that really needs to be at the center and not at the side of our discussion and our analysis. So I think about that. What else? You know, as we outline some mechanisms at the end of this conversation, you know, I was struck by saying that, you know, the statement that improving healthcare in California is going to lead to a reduction in the demand for healthcare. That struck me a particular way. We have operated on some assumptions here. I think we all agree on this commission that our current healthcare system is inaccessible. It's inaccessible to certain geographical regions. It's inaccessible to folks who are low income. It's inaccessible to a number of communities, our immigrant communities, folks who are English language learners, our LGBTQ community, of course, our BIPOC communities. And so if we truly make an accessible healthcare system, I would anticipate more folks are accessing that system. And so perhaps it's an analysis that really looks at how the healthcare system would change, more services, like some commissioners shared, in prevention, certainly more in long-term care, but how does that shake out in terms of a cost analysis? If we open our doors, to what degree will folks utilize healthcare in really, I would anticipate, remarkably different and increased ways? So I think about sort of all of those questions, and particularly related to what the cost analysis would be with those.
Thanks, Sarah. Sarah, I'm going to put you on the spot next, and then I was on a wrong page, and I see some hands up. I'm going to tee up 2 or 3 of those, and then I'm going to shift to our next point or discussion topic. So Sarah, then I saw Anthony's hand up and Rupa's hand up as well. And then I see Richard and Carmen as well. I'm going to, right after Sarah goes, Rupa, then Anthony. Then I'm going to pause just for a minute, get us into the next part of the conversation, tee that up, and then hopefully get to others. But Sarah, please go ahead.
Thank you, Secretary Galley. And thank you to just the organizers of this meeting. I really appreciate that we're having a conversation about financing that is also connected to cost containment, because I think it's so important to see those 2 things together. And also thank you to Ken Jacobs. I think that his presentation is very hopeful in that this financing the system is possible. Like it really is something that's realistically can happen. I do want to talk about the am I still on here?
We can hear you. We can hear you. We can't see you.
Can't see. Okay, I don't know what happened, but I'm just going to keep talking.
Yeah, please.
I do think it is so important that we have adequate financing and cost containment and reduction in the growth of healthcare costs. One, because we need a sustainable system, and we want to avoid the thing that Dr. Pan talked about capping services because we run out of budget. But the other reason is that we've had a lot of conversations about addressing the social determinants of health. And if we're able to save money, if we're able to eliminate waste, fraud, and abuse and inappropriate care in the healthcare system, that frees up more money in our budget to spend on things that address the social determinants of health that the healthcare system might not be able to do, like affordable housing, like mitigation of pollution and emissions at ports and under freeways and all of that. So I think it is important that we kind of see this healthcare system as embedded in the larger state budget, which makes it even more urgent that we reduce health cost growth and contain costs. And then in terms of reduction in the growth of healthcare costs, I think it's an overall reduction, but we also are talking about really a redistribution. Because right now you can have a hospital that has a marble lobby charging 500% of Medicare and maybe doing care that is not high value, that is inappropriate, next to a hospital that's not charging that. And like Dr. Wood said, is the reason that there's lower cost and better care in San Diego as opposed to Shasta, partly because of more competition and a lack of consolidation. And so I think we do need to look at where are resources distributed, not just kind of reducing healthcare cost and what we pay for services, but where that is. And we need to really get to both the prices that are charged, like Commissioner Costi said, it's the price is stupid. What is charged for care, and is the care appropriate and high value? So are we spending money where we are getting the best outcomes? And how do we regulate that and make sure that everything we're spending is getting the outcomes that we want in the places in the state that we want? And this goes to what Dr. Wood has been saying about needing to be able to have that data and track it and have accountability. And then lastly, I'm just going to say, I think we probably need a separate conversation at some point on workforce, because these questions are so important in terms of making sure that there are living wage, high quality, safe jobs in the healthcare industry, top to bottom. And also that we have the protections in there, that we're not reducing cost and then having hospitals come and say, we need to get rid of the seismic requirements, or we want to get rid of the nurse staffing ratios, because those aren't worker wages, but they are just as important in the system. So I do think the workforce question is going to be incredibly important.
Yeah, thanks, Sarah. I appreciate a number of topics that are coming up that we could commit an entire meeting to, and just in all setting expectations, we won't have a chance to do every one of them, and we'll get to scratch the surface on some of them, and then certainly the report will point to the need to continue to dig deep in some of these issues. Okay, so in the last few minutes, Rupa, you're next, then Anthony, and then we'll show slide 31, and I'll tee up a few other speakers. Go for it, Rupa.
First, I want to say I like the art behind you, Mark. It's beautiful. If we want to limit abuse, so fraud and abuse, but abuse specifically, what could we do to do that? For me, thinking about the financial abuse of the private healthcare industry in the day-to-day reality of our healthcare system is something that we really need to look at. In California, if your spouse dies, you carry that medical debt as the surviving spouse, and it becomes basically an estate tax that goes to these private health insurance companies. To sit, the soul-crushing experience of sitting at the bedside of someone dying of cancer who's had a protracted hospitalization, and being with the family who are simultaneously grieving their loved one and wondering if they're going to become homeless through the seizure of their assets from paying, a $750,000 medical bill. These are concerns that actually, medical debt is the leading cause of bankruptcy in the United States, and debt itself is an independent driver of inflammation. And all the diseases I see as a hospital medicine doctor, and that are the burden of our healthcare system, are chronic inflammatory diseases. So if we could take the bold step to abolishing the private healthcare industry, the insurance industry in this conversation, we allow ourselves the freedom to create new frameworks that can liberate the people from the financial abuse that has become sort of the background accepted reality of US healthcare. That is something I would like to see for the benefit of people. And we know that eliminating toxic debt actually does have immediate healthcare benefits. So looking at something toxic like payday loans, right? If you eliminate payday loans, you get a decrease in rates of fatal overdoses pretty much immediately. So I would love to see us take some bold steps and not limit what we're talking about when we're talking about abuse. The second thing I want to mention is going back to to Jim, what he was saying about diabetes and insulin, which I think is really, really important. Again, going back to air pollution, one of the leading causes of type 2 diabetes is air pollution. So if we are, again, atomized in how we're looking at this, we are not going to be able to drive down those healthcare costs enough until we are partnering at every level of the state to ensure systems are healthy. This needs to be a systems level analysis and not simply just looking at the healthcare industry as if it were separate from all of these things. And the last point is on diabetes and food systems. So currently in California, we don't have as much. There are some moves now post-COVID to change food systems, but we could be much more transformative in how we address access to healthy food. There was a study that came out of Paris that showed that of hospital admissions, people admitted to the ICU with severe COVID, 67% of them suffered from malnutrition. And if you look at the people in our communities where there are food deserts, still no access to healthy, organic, whole foods, those are the people who are showing up in the hospitals with severe COVID. So starting to understand that every admission doesn't cost the same, and the ones that are costing the most are people whose lives are being structured through all of these toxicities. So getting involved directly in the food system and really, codifying food as medicine, which is something that we're doing in the Bay Area, that, if we, give our community members complete zero access to healthy organic foods, how are we building up their health from the ground up? And that involves partnering again with our ag system and our farmers. So our farm workers are not abused, but really uplifted as the health workers, securing the health of our soils and the health of our bodies. So I just bring that in again to encourage us to think as systems wide as we can in this framing, and to start imagining novel partnerships that have not yet existed in the state of California to advance a network of health, a web of health that can improve, lift all boats. Thank you.
Thanks, Rupen. I'll just say, as somebody who gets to live at some of those intersections and have that privilege, I see that happening more and more because of the areas that you raise, and really a groundswell around a number of opportunities in California. Never fast enough, always more to do, but you start seeing that happen, and it is exciting. Okay, Anthony, you're gonna take us a little bit beyond my 45 minutes, but I'm good. And then we'll go into the next round of conversation.
Yeah, no, thank you, Chairman Galley, and thank you to Ken and fellow commissioners for a really rich conversation. On the issue, I think the list that we had on the slide was a really useful and important list of how we can help control costs. I think it's a lot of those things are things that we can do now. We don't have to wait. We can move now on things like setting a target, for costs, and frankly, for quality and equity. We don't we don't meet targets. We don't set. We don't, we can address a number of those issues. But I think we all recognize that unified financing, single payer would, in fact, give us more levers, give us more ability to meet and exceed those goals. That, in fact, that it gives us the tools to move forward in these areas. And I want to say that there's some things that unified financing gives us that's unique to unified financing as well. That it's a real opportunity. It's not just about waste and fraud, although I think that there is a portion of that. But I think it's more. I think about it more as misaligned incentives or market failures. That it's not an intent there is some portion of the system that is waste, that is fraud, that is intentional. But there's a lot of people who are acting rationally in an irrational system that are reacting to the incentives that exist in our fragmented system. And we need to fundamentally change some of those incentives so that people and providers and others want to get better, not just bigger, that the incentives are for better, not bigger, that the work that Commissioner Shuffler has done on consolidation suggests that that's where the payments go, rather than necessarily to the best quality, the most equitable care, et cetera. I think, as Commissioner Constey said, this is it's the price is stupid, quoting Uwe Reinhardt. And so this is So I think that that's why we're excited about the notion of moving to a unified finance system. And then the question is the financing and how you structure the financing. And so I do have maybe, I don't know if it's a question or a comment to Ken, which is just, we have this tension here between what is the best policy and the best and the politics of taxation in where you have a tax. We have something that we have done modeling that suggests actually would save money, would be great for the economy, would be good for business, would be good for workers, and yet by some it will be perceived as a tax increase. Now we know that tax increase will be replacing the money that we currently pay in premiums and in cost sharing, but number one, that the question is, how do we make clear to whether it's the business community, whether it's to a workforce, to workers and to families, that in fact there is this tax increase is this set of taxes is actually what you're paying for your healthcare. And so, like, for example, one of the tensions is, I don't know if you explored how some of these taxes impact behavior with regard to if it's seen differently, if it's like a lot of different taxes that may be more broad-based and so better from a policy point of view, but maybe there's some benefit to having something that is one or two very specific taxes, like how Medicare or Social Security are funded, where people know I'm paying this, but I know what I'm getting for this. And so we know that trade-off. And so when some of the political outfits that will oppose this say, oh, California taxes are high, you go, well, yeah, there's this tax here, but for that tax, as a prospective employer, I don't have to deal with the mess of having to, set up health benefits, because that's done for my workers. Like, and so I guess I'd be curious if you could just talk a little bit about how we could structure these taxes. And I'm interested in what Commissioner Rupa and others have talked about with regard to also having some taxes, a mix of taxes that would help promote health, whether it's tobacco or soda or other or pollution. But I recognize that in order to get to scale, we have to raise the money we need to do something that people will notice. And the question is, how do you package it? Or have you thought about how it could be structured so that it actually could either be clear what the benefit is, or how it could have the least impact on some of these other metrics about how you how people would perceive it?
Yeah, jump in, Ken.
Yeah, sure.
Thanks. Yeah, no.
Anthony, those are really great questions. And I think, looking at this right now, so you say, okay, right now offering employers and employee contributions together are 12.6% of payroll, right? So one could imagine something where you are replacing some large part of that with a tax that people would generally experience as either they're now getting more pay because that's less than what they were currently paying, or, in some cases, if no healthcare is being provided by their employer, that could result in an increase if those costs are passed to them. So then you'd want to do some kind of rebate to keep them whole. So you could set that up in a way that people experience kind of minimal change, and then supplement, and then that would be clear, this is what it's for. And that could be done either with the broad tax, where you're then supplementing that with the tax on profits, et cetera, or with the gross receipts, or with a tax on services. So you could do some mix there that got the part that people visually see right now on something that was roughly equal, and then the other parts covered. Nice thing about, the gross receipts, because it's spread over a small base, is very, it's something that's mostly not noticeable. And so I would think you'd want some kind of mix there. with making sure that you did those, as Commissioner Consti raised, really think about, okay, here's where the incidence of those taxes are. And so let's put in the rebates at the bottom so the people at the bottom are as well off as they are, better off now. And the other place I think about it is, okay, so who doesn't provide job-based coverage right now is mostly smaller businesses. So maybe you want to think about something there to minimize disruption as well. Of course, that means, then the rates are a little bit higher than they otherwise would have been. But I think that's some approach along those lines makes sense. Some combination of something that's very clear, but is replacing something people already do is a way you can help minimize that disruption and make visible to people what they're gaining.
I appreciate that. And just last point, I think that I don't want to take more time here, but I do think that it's a point for our next conversation about transition is this issue of how do you both this issue about how to sort of package these revenues so that they make sense to people and can actually inspire the kind of economic decisions we want, and then that makes California attractive, which I think this kind of shift would do in the long run. And then I would say two is I think the other thing that we would love to explore more, and I know you've thought about it a lot, is how you would actually make sure that, to the extent that certain employers are getting a real benefit from this switch, that gets passed on to workers.
I'll just, Anthony, I think for me, the question you just asked is the one that I have as a relative newcomer to the conversation, not decades, but years, right? I think this is one that is really important because I think you're talking about how people understand why we're doing what we're doing, how it affects their bottom line, one, but their experience too. And we talk about the more idealized healthcare delivery system, but then there's the background pieces of what people experience today. So I like the idea of including this as part of the transitions conversation. It's been one of the, I think it isn't the same conversation we've been having about what does the ideal system do? How do we get there? This is really about how we include all Californians in supporting it and benefiting, reaping the benefits. So a very important question. I know that I've spent time with the consultants talking about it because it is one that I think when you look at some of the other stories of where this hasn't worked out, I don't know that they've handled this question as well as I think they would have liked to. And so that's going to be a really important one. All right, I'm going to just put up some slides. I see Richard and Carmen, your hands up. I'll get to you as well. Can we put up slide 31, the final one? So just leaving us about 35, 40 minutes for this part of the conversation before we go into public comment. Beyond cost containment efforts, what additional structural changes will be needed to assure the system that we get what we want from the system? And I wanted to take a minute and talk about governance. I know Carmen and Richard, you were actually on my list of people to pull into this part of the conversation as well. But before we get to you, I want to, Bill, I teed you up earlier just to talk briefly about some of the experiences you had grappling with governance structures in the work you did internationally, and how you would say the structures can help provide that optimal level of oversight while assuring that we're delivering towards the goals that we ultimately lay out for the system. And then as a second related question, I think we've gotten to a little bit about prioritizing workforce and thinking about information technology and exchange, but what other investments should California be considering to really set us up for success? So Bill, maybe I can go to you for just a few minutes and then go to Carmen, Richard, and then I'd love to pull in some of the other commissioners that haven't had a chance to share their perspective on this issue and others. So Bill, take it away, please.
Well, let me start by trying to give a definition of what is governance. and then I get into some specifics. One definition of governance is the role, the power, the responsibility, and the accountability of different parties or different key players in the system. So one of the major questions usually in setting up a governance in a unified financing system is, what's the role of the, let's say, state level? What's the role of the county level or regional level? And and also, to what extent you want to make sure you get the people at the grassroots level engaged actively in that governance structure. Let me just then get very specific. When I worked in Taiwan, the president of Taiwan called me once and said, he has thought about this unified financing for Taiwan, which is called national health insurance. He said, I want you to design a system that takes the government out the middle. He had experienced that people who get the benefits from a healthcare system always want to more and more and more. Then the people who have to pay for that usually want to say, I cannot pay even a penny more. If the government is in the middle, then everyone's attention is on the government. And all the pressures then are on the governmental leaders or the legislature. And so he wants to insulate that. Actually, if you look at some other countries like Germany, that's really also what Germany eventually went to. So how does Taiwan does it? Taiwan sets the executive branch in consultation with the legislature to set a target, aggregate upper limit, say what's next year's budget spending, the maximum could be. And then there is a council that represents with the representatives from people who have to pay. That's including the workers, the business, and including the government itself, because the government has to subsidize the poor people and so forth, and sit down and with the people who receive the money. That's the hospitals, physicians, nurses, and as well as the public who wants to expand the benefits. Then there's a third group, which are academics, because usually those two parties may reach a deadlock. So there has to be a group of people who represent the unbiased public involved to try to, and that's how Taiwan does it. And I will not bore you with how Germany does it. It does it a bit differently, but basically it's also, the question is, how do I really govern, first of all, decide on the overall spending for next year, setting that target. And then the question next is, how do we allocate it downward? In Germany, it's every state. Taiwan only had 24 million people. They divide Taiwan into 5 regions. California has 40+ million people. I'm sure California will have to allocate budget down to regions or counties. And then going back to this governance structure, then is what role do you give to each one? What's the power do they have? Then what responsibility? Then at the end is the accountability. That all have to be spelled out. And so I just want to use that as an introduction and to summarize it this way. Do you want everything to be handled by the government, or they only play really a very high level role to rectify or reject some civil organ council, which with different interest parties negotiate out the income, out the result on how much we're going to spend in total for next year? Or so you're going to use the legislature, or you're going to use the governor's executive power? Those are, to me, are really critical issues in governance. Then how do you allocate the roles, responsibilities, and accountability down to regions? So let me just open with that introductory remark.
Thanks, Bill. Always value your perspective and experience, actually having done it. Part of leaving both Richard and Carmen as our next commentators, I want you, I know you both have thought a little bit or a lot about governance and from different angles. Would love, as you formulate other comments, would love your perspective on this piece as well, as it's an important part of our conversation. And then I want to make sure that I pull Andy and Michelle in after Carmen, you go, Richard, then maybe go Michelle and then Andy, really kind of looking to your both kind of experience in those large public systems and thinking about how either tools around governance or other levers of control on some of these important aspects that we've talked today, whether it's on cost containment or making sure that we're driving towards some of these other principles of access, quality, and equity. Would love to just draw on your perspectives and experiences as well. So with that, Carmen, you could go next, and then Richard.
Sure. I think I try to formulate my comments in response to the question. What's the I kind of find it a little bit interesting to me because what are the structural changes that we need? I mean, the simple answer is that we need to adopt a single payer system with a single standard of care and a single plan for everybody. We've been talking about this over the past 22 months of this commission, and that's the single most important structural change and governance change that we could make, is getting us to a single plan for everybody that's universal. That's how we get all the savings that have been laid out in the economic modeling. And I think what's really important also is that we have to, it is the reduction of the administrative waste with respect to fragmentation and complexity. So like I think I want to point out here that in the modeling that the consultants have done, the money that we spend on billing and health insurance created administration, that, as I've said a lot, that could be spent on care. And like, if we look at the modeling, the health plan intermediary option versus the direct payment single payer option, the health plan and intermediary option is more expensive than the single payer option. And I think that's a really important point to point out there, because the administrative waste causes increases in the cost of the program. So simplifying the program so we have a single governance structure is really important, so that that we can more precisely exercise the regulatory oversight of providers so we can ensure access, quality, and equity. I think that's really, really important in our discussion and in putting together our recommendations in the final report. And I think, you know, we had to really emphasize that creating more complexity increases the cost of the program. And, you know, I think one of the other types of things that are broader kind of sustainability measures that we could do, you know, we've talked about them, you know, Ken talked about them, everybody else has talked about them over the course of the meeting, you know, which is direct negotiations with providers. And I think that's where the hospital global budgeting and negotiating the individual provider rate structure is really important. And, you know, how we get there is that we have a single bargaining entity on the opposite side of that. You know, in a single payer program, that is the government entity that we identify as as our bargaining agent, if you will, to negotiate those prices with the hospitals and individual providers. And like we do in CalCare in AB 1400, we have other control measures within that negotiation structure, again, to ensure that payments go towards care and not profit. But we literally say that care has to go back to that reimbursements have to go back to profits and not net revenue. And, you know, we have controls saying that there can't be excess corporate health executive compensation. You know, there's measures to have valuation of services. So we have that redistributional effect that Sarah was talking about. So all these things are super important. But then in terms of like, you know, the entity that does the oversight, I do think, you know, I want to caution us against, you know, having the providers self-regulate. And I think that's one thing that I know, I went to Taiwan, I talked to a lot of folks there and in the National Health Insurance Program and administration. And, you know, I think that's one of the things that they were struggling with, which is like that perhaps there was too much self-regulation. And I do think it's really important that the single payer system, the government entity, the board that we create, or that is identified to be the overseer of the program, you know, has control over regulating fraud and abuse. Because I think, you know, it's important that we're identifying all of the potential, you know, I hate to call it fraud and abuse, because I think that's what's really important with having a single payer system, is that we can investigate, you know, why providers potentially are outliers in their utilization or how they're using the system or how they're providing services. And then we can kind of dig deeper into why that is, because, you know, a provider could be using more over prescribing relative to their peers, because, you know, their patient population works in an industry with high exposure to carcinogens, or, you know, their patients may need a lot of pain meds because they're mostly from employers and industries who won't provide them you know, physical therapy or time for surgery. So I think those nuances are really important, because we can't just say, you know, I think the definitional issues with fraud and abuse are really important here. And I think that's why a single payer system with the government doing the oversight is really important, because we can dig down into the why of the question and to more effectively answer the why, rather than just simply, you know, penalizing doctors without really understanding what's happening. And I think that's really important in how we govern the system. And I think, you know, another thing from from AB 1400 and CalCare that I want to point out is that, we take advantage of the single payer direct provider to system relationship by adding in conditions of participation, controls on diagnostic and procedure coding and financial incentives that incentivize providing more care or more expensive care just because of the payment structure. And I think that's really, really important, particularly with, again, the DOJ's litigation against Kaiser for their alleged coding parties that they have, that it's really important to get rid of those incentivizing mechanisms in the payment structure. And I think we can do that with conditions of participation. So, I think one last thing on administration and governance that I think is really important too is one thing that we haven't talked about is how getting rid of billing and administrative waste frees up time for nurses and doctors to actually spend on care and providing more care. And, I know the CBO has made actual calculations on what that means in terms of how much more care we could provide to people. And I think, there's also the Stanford Business School study on administrative sludge, which cost individuals time and energy, kind of what calling back to what Rupa was saying, there is a real cost of the administrative bureaucracy of our for-profit health insurance system that has a real effect on both providers and patients. And that really is important to get rid of that. And, I think there's a lot of moving parts here. And I think, to answer that last question in the discussion list, what we really need to prioritize in investments is care, so that we can have prevention and primary care, so that people aren't going to making people healthier and making the population healthier, the state of California healthier, makes the system healthier in terms of both cost and financing. And I think that's really a really important concept that we have to keep in mind, so that we're not trending towards like, how do we limit services to so that we can keep a cap on the cost of the system overall. And I think, I say it a lot, but I do think it's really something that we have to remind ourselves of.
Thanks, Carmen, Richard, and then Michelle and Andy. We have about 15 outside 20 minutes before I want to wrap us up and get to public comment. So keep that in mind. But Richard, please go ahead.
Oh, thank you. First, one brief comment before I talk about governance. I know we had discussion about revenue. I appreciate Richard Scheffler bringing up Millionaires tax and excess profits revenue, but I think we have to look at not just the amount of revenue, but volatility. So our state budget's very volatile because we're so dependent on high income earners for our state revenue. So we got to keep that in mind, knowing that healthcare spending is not that volatile. I mean, maybe going up, but it doesn't. In fact, it tends to be counter-cyclical. So just want to make that mention in any sort of revenue approach. In terms of governance, I think there's a few things I want to keep in mind about governance. So I'm sure there's a bunch of things that we all want that we out of the governance, but first thing I always keep in mind is that in governance structure, the rules are the same no matter who's actually running the ship, which means that, for example, I would make note that Donald Trump was president of the United States. And we can argue about how legitimate he is, so forth, but he was elected under the rules. And so, you can have a Donald Trump running the state, okay, or certainly ran the nation. Just have to keep in mind, whatever rules of governance we set up, it has to be, we can't make assumptions about who's going to make the decision, certain decisions, and so forth. So I think it is important that we design governance systems that are robust, that also are somewhat insulated from sometimes some of the political back and forth, so that there's some stability. The other thing is that I want to also keep in mind is that when we do governance is that, so there's some reference to a single board and so forth, is that, again, maybe because I'm in an elected official in politics is that oftentimes if you just have a single entity that has all the authority, then of course, I think as Bill Schau mentioned, is that obviously the stakeholders will weigh in and be sure they dominate that body, and for good reason. And oftentimes we've seen this over and over again, especially as we talk about equity and other types of things. It's minority groups that tend to lose out in those situations if we overly concentrate power in a particular entity. And so whether it's disadvantaged communities of color, or people with rare diseases or other types of things where they tend to be minority but may need to have a disproportionate share of the resources in order for them to get the care they need. So we do want to think about how much we want to concentrate versus diffuse power in a way that allows these more minority communities to be able to be empowered to be able to get the resources, at least get closer to the resources they need. Some of this perspective perhaps comes from the fact that I'm a pediatrician. And so what I see is a lot of times health policy is driven by the needs of adults, because after all, there's more of them, they vote, kids don't. Adults spend more as a proportion, right, than the kids do. Kids are generally healthier. So therefore, generally we design systems, we do things, we allocate systems in ways that are designed for the majority. And so if we overly concentrate power. So I do want to raise that issue. So obviously I'm not providing specifics, but I think we need to think about these things. Do we want a single board that has all this power versus diffusing it out into different ways so that communities actually have the opportunity, more disadvantaged communities actually have the opportunity, and more grassroots efforts have the opportunity to be able to guide the resources in the way that they see fit. I make mention bureaucracy. Bureaucracy is present everywhere, both in public and private systems. So, I mean, the word bureaucracy comes from government. So, and I think we need to acknowledge that just having a unified financing system, especially, doesn't mean that bureaucracy goes away. I keep that in mind. I would point out, for example, sort of going back to my previous point, let's take Medicare, our single payer system in the country. Rural communities are disadvantaged in payment by design. And interesting enough, because Sacramento, when they set it up back in the 60s, was considered rural. We actually we've lived under those rules too. So again, this goes back to being sure we don't overly concentrate power. The other issue I want to bring up is that there's conversation saying that everyone's under a single plan, but I think we have to have an honest conversation about to the degree people can actually who have the means go outside if they wish to, because we don't provide what they want or what they desire. So in Medicare, we have Medigap plans, we have Medicare Advantage. So that's our single payer system. I'll tell you, our public school system we can't ban people from opening and sending their kids to private schools. Yes, they have to pay the taxes that support the public schools, but they do, whether it's realistic to say you can't go outside, right? Now, so that's always a tension too, right? So, and then I do appreciate what Bill Schau said in terms of talking about exactly how much detail you actually want your governance entities to get into, the nitty-gritty details, and then how and what the dynamics are of that if they make those kind of decisions. And so, I think certainly I appreciate Carmen saying that perhaps Taiwan made it too loose, but I think there is some question about how, exactly how nitty-gritty you want your government entities to, and the higher you raise the stakes of the governance body, the more, then clearly there's going to be entities that are then going to want to be sure that they, have more influence over that. And again, that raises the stakes in other ways as well. I do just want to touch a little bit. I know this was more on the previous panel, but something that, some of the issues of low value care, and this does tie to governance, right? So what's low value care? Is prescribing antibiotics for people with colds low value care? Most experts would agree it is, but we know there's some groups that want it. patient groups. That's their expectation. By the way, we see this in Taiwan, right? And so to what degree, when you have conflicts between what some people would judge as low value care versus certain communities saying, no, we want this. We saw this fight go out, by the way, back when people wanted to do bone marrow transplants for breast cancer, and Kaiser was, demonized for refusing to pay for those, and then got under so much public pressure. I think they had to cave in, right? So we have to recognize that there are some limits to what an entity can do, both public or private, in terms of standing, in terms of issues around low value care. And then fraud and abuse. By the way, I should mention, I was one who authored legislation for the state to manufacture drugs. I actually oversaw, as chair of the Assembly Health Committee back in my day, hearings around fraud in Medi-Cal, particularly around substance use counseling. There was a big issue there. I've supported legislation for the claims-based database, and of course support. So we should definitely go after fraud and abuse. But I also want to make mention, talking about abuse, is abuse on the other side. Okay, so I was at UC Davis for basically turned out for 10 years. The state of California, through its Medi-Cal program on the fee-for-service side, actually denied all our claims for PICU patients. Because our billing department didn't bother to follow up and they were all rejected, they never got paid. And then finally someone did, the department decided to engage in an audit and found out that all the claims were legitimate. Turned out that the state of California cheated the department by over $60 million. And then when that was all revealed, the state said, well, guess what? You have to refile all your claims then, going back 10 years. We refused to pay. So, so we have to be sure those types of things don't happen either, because if you want trust in this system, and this is the government, the state, manipulating their own claim system to essentially try to save, save money, and in a way. So, so yes, there is fraud. We need to stamp out fraud. I've been involved in stamping out fraud, but we also need to think about the abuse on the other way and be sure that our system doesn't abuse providers as well. But certainly I think on the governance side, there's a lot of thinking to do about that. And we really got to think about what's this balance between concentration and diffusion of power, especially in relation to, how we ensure there's equity, how we ensure that disadvantaged communities, whether they're, communities of color, they're rural communities, they're people who have really specialized needs, who are rare, have a say. And then we need to really think about exactly, and the reality that depending on how we'd set this up, there are going to be, I think the courts would even rule that if someone wanted to spend their own money on healthcare, you can't stop them from doing that, and from selling those services to them. So with that, I'll wrap up. Thank you.
Thanks, Richard. Lots of really good points on a number of issues, including governance. That I think your point is that we have a lot more to talk about on governance than we've had time to, no doubt. All right, I think we'll go to Andy next, and then Michelle. And Michelle, you get the distinct pleasure of being our final comment before we wrap things up and go to public comment. Andy?
Thank you, Mark. I'm going to be real fast. 2 quick points on governance and oversight. The first is, one of the things to consider as we structure this is, who is the federal government going to be willing to negotiate with? Because to claim those 12 billion, if I'm reading Ken's excellent, thank you very much, Ken, for doing it, excellent estimates, in 2031, there's 12 billion in federal savings on the table under the 0.5 percentage point less of NHE scenario. So negotiating all of that, again, as you know, I think you have to go to Congress and negotiate, is something that someone will have to do. And the question is, if you have an independent governance structure that's independent of the state government, will the federal government be willing to talk to you? I have my doubts. So that's one thing to consider. The other thing is, whatever governance structure you've got, given the complexity and the scale of the California healthcare system, there's going to be a bandwidth problem in terms of oversight and monitoring. It's just inevitable. There won't be enough eyes. And one potential solution to that, not a total solution, but sort of a mitigation, is transparency. And I'll just give you a brief example. So my organization, the Center for Children and Families at Georgetown University, we have been very interested in persuading state Medicaid programs and state CHIP programs, child health insurance programs, that contract with managed care plans to post the performance results on a plan-specific basis on their website. How many child screenings is each plan providing? How do those break down by race and ethnicity? Just tell us what you already know, the information you're already collecting about how a plan is performing. We call it a child health dashboard. And a number of states, including California, to its credit, have a child health dashboard, but it's not specific to a plan. And if it's not plan specific, no one can do anything useful with that information, right? The consumers don't know what they're getting into. The providers don't know who they're signing up with. The plan management have the benefit of opacity and being able to continue doing what they're doing, whether it's good or not. The poor performers are shielded. The good performers don't get the benefit, reputational and otherwise, of we're a good performer, look at this, it's right there. So I think there's a lot of benefits to transparency just on the basis of information we're already collecting. And it doesn't cost very much.
That is a really excellent point, one I know we've talked a lot about and have increased that ability here, but to your point, is it as specific as it needs to be? I think there's it's a good conversation for us to have outside of this commission as well, and no better person to lead that conversation for us in California than Michelle. Michelle, turn it to you for some comments too.
I'll be very quick. I know we're trying to get to public comment, but just in terms of the topic of governments, I think the academic questions that come to my mind are, will decisions be made at the state level? Will regional differences be considered? And how do we foster innovation at the local level? What are the policy rules versus the financing rules? And does the same body make these decisions? However, I think fundamental to the topic of governments is the commitment to a vision for the ideal system, and in particular on this topic. As I think about the goal for, I think we called it the ensuring access, quality, and equity, I think about experiences in other countries like Costa Rica and how their results highlight the focus on integration of public health and primary care. The emphasis on the primary care workforce and community health workers have resulted in not only better outcomes, better health outcomes, but also spending less. They've designed a model where it's not reactive. They've designed a structure where both at the national and local level, every community has a primary care team that's able to provide visits to all its residents. So I think that kind of common commitment is critical in terms of a governance structure. So everyone is united in kind of where it's going. That's all I have.
Thanks, Michelle. By way of wrapping up, I know we could be at this for another couple of hours, and I know many of you held back a little bit and had a chance to connect to 2 times, maybe somebody got in there 3 times, but I just want to thank you all for your patience and your ability to sort of get your point in, even if we sort of moved around a little bit, but I think that the conversation is terrific, and I know we could say more. I thought Michelle's last point, I think, is a really important one. And one of the things that I wanted to sort of conclude with, which is what I think Ken's presentation has done. And I know many of you said, well, duh, that's been there the whole time, as my teenage daughter would say, duh, Dad, that's been there in front of your face the entire time. But the point is that Ken kind of walked us through how this is a real potential, right? That the moving moving to a system that under unified financing gives us a real chance not just to have something that's more affordable for Californian and Californians over the next decade with some important assumptions, gives us a chance though to also not just get the same thing that we get today for less money or in a more well-distributed way, but to really get, as Michelle just concluded with, a system that I think is built around the values and the propositions that we've been committed to all along as a commission. And I think that connection of not just different costs and affordability, but the real opportunity to redesign something that addresses some of the workforce crises that we've been grappling with and will face more and more, the equity issues and the power dynamics, the focus on prevention, the focus on care of the whole person, the opportunity to talk about long-term services and supports in a different context and way, and building it in at the front end. So not just on the dollars and cents side of it, but the reminder that that isn't the only part that might make sense here, but really an opportunity to build the system in the wake of COVID, in the wake of persistent ongoing inequities and disparities, that we have a terrific chance to sort of bring something together. And so I know that many of you have been there for a long time, but to see the whole commission sort of move there, I think is an important declaration and point that will help us as we craft our final report and think about these last months of our work together. So with that, Karen, I think you've already teed up, or people are ready to go for public comment. I encourage commissioners to stay on as much as you can, listen in. I know it's been a long meeting. People's stomachs are grumbling on the West Coast, but thanks for giving our public team a chance to weigh in and hear their thoughts.
Thank you, Secretary Galley. Indeed, we will now be opening things up for public comment. We will be enabling the chat feature for written comment at this time, and we will be taking verbal comment from members of the public following the cue that's in the participant panel of the virtual raised hands. We'll take as much comment as we can until just before 12:30 Pacific time. If you are making verbal comment, once I invite you to unmute, please state your full name and any affiliation you have with an organization that's relevant here. And please know that you'll have 1 minute for comment so that we can accommodate as many people as possible. I appreciate in advance your cooperation. Would hate to have to mute in order to move on. So appreciate in advance your cooperation around the 1 minute mark. Okay, and with that, let's begin. Isabel Story, please go ahead.
Okay, I wasn't quite ready to be first, but okay, let me pop into action here. So I'm Isabel Story with Indivisible California, a coalition of 80 groups. We've been watching these commission meetings very closely, and we just want to make sure that the final report is really a strong step to enacting a single payer healthcare system in California. You know, we have 3 million Californians uninsured, millions more underinsured, and we're in the middle of a pandemic. And so the time to enact a single payer healthcare system that works for everyone is now, or maybe even yesterday. The questions of financing are very important, but we need to design the system first. I'm going to repeat that the Commission's ignoring of AB 1400, I believe, is a mistake. The legislation lays out a fully developed system with unified financing. It should be considered and evaluated.
Thank you, Ms.
And I just want to say the Commission should also do its part by studying and proposing different methods of financing.
Thank you very much. Sean Broadbent, please go ahead.
Thank you. Afternoon, Commissioners. I'm Sean Broadbent, co-chair of DSALA's Healthcare Justice Committee. Instead of pondering how specifically we are going to finance a single payer system, we should be spending our time deciding exactly what that system is going to look like and come up with a wide array of options that could be combined to fund that system. The Commission should evaluate the potential options to raise revenue, to fund a single payer system, including how much each option could raise at varying rates or with different exemptions for working people. This is why, as an elected assembly delegate, I've authored a resolution for consideration at this weekend's executive board meeting, saying this is the direction the people of California need the commission to go in. We need the commission to articulate an operational path for a single payer unified financing system in its final report to the governor and legislature, especially in a manner that eliminates the role for health plans or risk-bearing intermediaries that make it harder and more expensive to access care. Thank you.
Thank you very much. Kayla Westergaard Dobson, please go ahead.
Hi, my name is Kayla Westergaard Dobson. I'm also a member of DSALA's Healthcare Justice Committee. Thank you to the Commission for the excellent discussion today and for moving the conversation forward on healthcare access for all Californians. But the Commission has a well-developed blueprint for unified financing available for discussion right now in AB 1400, the California Guaranteed Healthcare for All Act. Instead of ignoring it, the Commission should let Commissioner Comsty present on it. As someone born and raised in California, my life has been immeasurably rocked by the lack of a single payer system. The current insurance system means that I've now paid over $10,000 out of pocket for the birth and death of my son, Arthur, in December 2020. As a commission meant to discuss keeping Californians healthy, you can't achieve that when Californians are forced to continue enduring medical trauma and subsequent financial trauma while we wait to design a perfect system. Unified financing is another way of saying single payer. Please discuss AB 1400 now and help create a healthcare system that won't leave people like me out in the cold ever again. Thank you.
Thank you very much. Cindy Young, please go ahead.
May I unmute? Good afternoon, everybody. My name is Cindy Young. I'm co-chair of Healthy California Now, and I want to, this was a fascinating meeting. I want to thank Ken Jacobs for that excellent presentation and the discussion that that took place afterwards. I just want to remind the Commission that the Kaiser Family Foundation recently came out with its annual employer survey, and it just speaks to the urgency of moving forward on a unified financing system. You've got most workers make a contribution towards the cost of their healthcare premium. On average, coverage workers contribute 17% of the premium, and for single coverage, and 28% for family coverage. In dollars, that amounts to about $1,300 per worker for single coverage and almost $6,000 for family coverage. So as you're thinking about how we finance this, there is already a huge burden on the employees, but also when you look in the future and you look at the plan designs that are being offered by the insurance company, you're seeing high deductible, narrow network plans that don't serve the needs of our community. So I want to thank you and I encourage the Commission to keep up its good work and to continue to move forward on the unified financing system. Thank you.
Thank you. Bill Honigman, please go ahead.
Thank you. Can you hear me?
Yes, sir.
Yeah, Bill Honigman, retired emergency room physician. As a medical professional who has witnessed the harsh inadequacy of our current commercial interest-driven medical care in California over decades now, I believe the financial sustainability with a unified system for universal health care in California is a matter of settled economic and public health science. Study after study by independent and academic analysts alike over decades now show overall costs are less than what we're paying now, and significant savings to individuals, households, businesses, and all public agencies, with the potential to save so many lives and relieve so much suffering in the state exists. A myriad of possible mechanisms for funding the program have been suggested over the years, and the legislature needs only to settle on a few particulars suggested by this panel, put into CalCare AB 1400 and move the process forward. Please do exactly that. Now, make your best suggestions on a particular mechanism for funding the new system, and let's get on with saving lives and saving money, as the science tells us it most certainly will do.
Dennis Resendez, please go ahead.
Good afternoon, everyone. My name is Dennis Resendez. I'm from Azusa, and I'm an elected member with Los Angeles County Democratic Party. I'm here for two good friends who, despite having jobs, still had to engage in two different GoFundMe campaigns to pay for the care of their prematurely born baby. In a country and state as great as ours, GoFundMe should not be a way for working families to pay for critical reproductive care. My two For my two friends and for so many other reasons, I believe that healthcare is a human right. Failing the United States government, the state of California must provide guaranteed comprehensive not-for-profit healthcare to all residents of the state. AB 1400 or CalCare addresses most of the questions this commission has devoted its time discussing, including how we reimburse providers, how governance works, and what the waiver process looks like, and more. If you truly believe in healthcare as a human right, then you will recommend the governor push the state legislature to pass AB 1400 so that he can sign it into law. Thank you.
Thank you. Sarah Roos, please go ahead.
Thanks for the opportunity. I'm calling from West LA to say one's chance of surviving cancer shouldn't depend on whether your daddy has strategically secured good health insurance for his family. But that's why I'm here talking before you today. Nearly 40 years ago, I was diagnosed with a pediatric cancer almost no one survived. After my family stopped crying over statistics, they researched protocols and discovered one solitary physician gaining unequaled results with my malady. They were able to arrange treatment with him because and only because I had health insurance that allowed me to visit any doctor in any state at any time. That was the perk of my father's low-paying academic profession. His whole family benefited from a large group health insurance plan. His calculated sacrifice of salary for benefits paid off when catastrophe struck, and likewise, folding the state's entire population into one giant health insurance plan is the most efficient, indeed, the only way to solve the problem of sharing such risk among everyone collectively. Universal healthcare maximizes benefits for citizens, not corporations. As a democracy, that's what we are, a government concerned by and for the people. I beg this commission to get on with the task of supporting single-payer healthcare. You're clearly juggling many parameters, but at its root, AB 1400 is the form I support. It saves money and...
Ruth Carter, we're going to invite you to speak now.
Good morning. Well, good afternoon, everybody. Thank you to the commissioners for the important work that you are doing for Californians. My name is Ruth Carter, and I'm the chair of the California Democratic Party Senior Caucus. And I'd like to speak from the perspective of the United States, while being one of the wealthiest nations of the world, is far from the healthiest. Even before the COVID-19 pandemic, Americans live shorter and less healthy lives than people in other high-income countries. We have the most expensive healthcare system, yet the worst healthcare outcomes. However, the US health disadvantage changes dramatically at age 65, when the USA rises very near to the top when compared to other first world countries. And yet what happens at age 65? People have access to quality, affordable healthcare through Medicare. Therefore, we are asking this commission to advocate for a publicly financed healthcare system that, as Ken Jacobs concluded, will increase equity in financing and delivery for healthcare. Thank you.
Thank you. Bryn O'Neill, please go ahead.
Bryn, CNA. A single-payer system would rein in the rise in healthcare costs. First, we know that single-payer saves money every single year. Second, AB 1400 has several specific features for a single-payer system to keep costs under control while ensuring that everyone gets the care that they need. Under AB 1400, provider global budgeting ensures that hospital spending reflects the actual costs of providing care, preventing hospitals from raising prices to extract huge surpluses. Individual provider rates will be negotiated collectively and set at reasonable rates. The state will save money through bulk drug price negotiations. Plus, AB 1400 has specific mechanisms to counter ways that providers manipulate payment incentives to maximize profits, such as inappropriate diagnosis-related coding or bonuses for high utilization. And the system would maintain a reserve to respond to health emergencies and economic fluctuations. AB 1400 will let us provide equitable healthcare to all Californians for the long term. Thank you.
Thank you. Elsa Schaefer, please go ahead. I'll try to unmute one more time. There we go.
Good, did it. Thanks so much. I'm Elsa Schaefer. I chair the Healthcare Task Force of San Mateo County's Democracy for America. I cannot be more thrilled about the direction of this conversation today, the caliber of the people speaking, and have much to carry back to my people. Thanks so much. I love the concept of looking beyond specific healthcare itself into the related areas of affordable housing and food. That was fabulous to hear. I suggest that you use the team that created Al Gore's slides for Inconvenient Truth to do that translating to the public and to physicians and to hospital groups, because they, better than anyone else I've seen, have been able to create the story and the simplicity of getting that point across. I also am so grateful to hear so much about the Taiwan healthcare system, and have heard people say, oh, but we're only California, we can't do it, the Fed has to do it. No, if Taiwan can do it with 24 million people, we with 40 million also can. I'm so grateful for the commission.
Thank you. Philip Kim, please go ahead.
Hi, Philip Kim with the California Nurses Association. I'm in Sacramento. The commission needs to help California legislators figure out how to raise the necessary state revenue to replace premiums, deductibles, and copays that were charged today. The commission's consultants should create an interactive online calculator to show different state revenue options. The public and legislators can use it to look at different combinations of taxes on payroll, gross receipts, corporate profits, high-income households, as well as redirected revenue from corporate tax exemptions, charity care tax breaks, and policing and incarceration. Each source will have different political and legal considerations. With the options on the table, the legislature can start doing its job debating and discussing a financing plan and tackling any barriers that exist. We can't keep spending too much money on too little healthcare because our elected officials are anxious about tax law. So please use the commission's multi-million-dollar budget and instruct the consulting staff to create an interactive online calculator that would be useful for legislators and the public as we push for CalCare AB 1400. Thank you.
Thank you. Beatrice Sosa Prado, please go ahead.
Hi, good afternoon, everyone. This is Beatriz Sosa Prado, Executive Director at California Physicians Alliance. And CAPA has shared with all of the commissioners our roadmap to Golden State Care, strategic steps to get California to universal coverage and an equitable healthcare system. It's essential that we reframe concerns about taxes and untenable state budgets to financing based on affordable public premiums deposited into a trust fund separate from the state budget. Golden State Care can be financed through several possible methods. First, the focus must be on decreasing prices where they are unjustifiably high. And larger risk pools ultimately, which we will eventually could have a larger risk pool for, will decrease actual costs and prices. Second, multiple revenue sources are possible and continue to be mentioned in these meetings. For all covered benefits under Golden State Care, the new revenue sources would replace all or nearly all out-of-pocket expenses, deductibles, and copays, etc. And so I encourage the commissioners to read CAPA's roadmap in hopes that it will be helpful to you as you write your final report to the governor. Thank you so much.
Terry Brady, please go ahead.
Thank you. My name is Terry Brady. I'm the chair for the Foothills Coalition for Universal Healthcare. This has been one of the best commission meetings thus far that I've been able to experience. So thank you to everyone. This is too important an issue to not invest in a single payer system like AB 1400. This is one of the most critical issues facing all Americans now and in the future, healthcare. We must educate, educate, educate. As was mentioned during the meeting this morning, the 20-year effort to turn around our society as it relates to smoking took a serious investment in educating our society. Unless we give the same attention to supporting an informal and formal education program and campaign to inform all segments of our general population exactly what a single payer system is and will provide them through improving their total health status, it's cost effective and will save everyone money. We must seriously start that education outreach campaign now, not later.
Thank you very much. Ryan Skolnick, please go ahead.
Thank you. Ryan Skolnick with the California Nurses Association. And I want to quickly address the claim that employers are going to pass on potential costs of a single payer system to workers and consumers. Because on its face, it may sound plausible. But the reality is this claim is incredibly misleading because it ignores the reality that under our current system, it's unsustainable for workers, and that the costs of our current system are already passed on to workers and consumers, both directly and systemically. Job-based health insurance depresses wages and other benefits. Insurance costs are growing faster than incomes. Deductibles are growing 10 times faster than inflation over the last decade. Families spend thousands every year on premiums and deductibles, and these are only expected to skyrocket. Employers, as we've seen over the recent strikes, hold health plans hostage to extract concessions at the bargaining table and to retaliate against striking workers. The reality people are talking about might happen already exists now. Single payer would end employer stranglehold over our health, boost worker bargaining power to negotiate better wages and benefits and working conditions.
Thank you, Mr. Skolnick. Jenny Chang, please go ahead.
Thank you, Commissioners. I'm with the E-Board of the State Democratic Party. I'm also with California Alliance for Retired Americans and Healthy California Now. Thank you, Ken Jacobs. It is encouraging to see your presentation in this space. I'm not getting total clarity on what unified financing means, whether or not it's single payer, but I call for a sincere effort to abolish private insurance companies. You know, it's so clear that the practice of profiteering off health has been detrimental to the health system and increasingly challenging for those who practice medicine. And as this body is considering a change in holistic, equitable way, systemic change, I'd also like to underscore the importance of including LTSS, long-term services and supports. As someone whose brother is an incapacitated person and my late father was also physically disabled, I can tell you it takes great toll on families, and support services are about individuals' well-being and economic independence as much as it is about family and the larger community, and the caregivers. So dare to think creatively and think outside the box. And I love the challenge that Dr. Shao, he's constantly prompting for the body to rise to the challenge to do something extraordinary for California to set the standard. Thank you.
Thanks so much. Quintilia Avila, please go ahead.
Yes, good morning. Good afternoon. Thank you for commissioners for having this meeting. I am a volunteer for the California Nurses Association. I'm a naturalized citizen, and being as a family from immigrant background, we always had struggled for having healthcare. My dad was legally blind, and we know that there are so many people that need healthcare. The pandemic has really highlighted this. 40% of Californians are Latinos, and they are the ones who are most impacted by this pandemic and need healthcare no matter where they go, whether it's a new job or not. So it should not be employee-based. I want to make sure that I think that AB 1400 has all the elements that you are looking for, and it is the job of our legislators to figure out how they're going to fund it and all the details. But it's important that they really set up a system that takes care of all of Californians, no matter their immigration or employment background. Thank you for having me today.
We just have time for 2 more speakers. So if you're in the queue, I apologize that we weren't able to take you today, and welcome you to include your public comment in the chat while it's still open in the last few minutes of the meeting. And with that, I'll invite Scott Johnson to speak.
I am in Auburn. I'm a small business owner. I tune pianos. My wife is a picture framer. We both have had to forego healthcare in the past because it's unaffordable, even though we have insurance. But I'll tell you the stories of 2 of my colleagues. The man I learned to tune from was blind. His wife was legally blind. She had cataracts, and she went for many, many years with her cataracts getting worse, and she got more and more blind. It wasn't until she got Medicare that she was finally able to afford surgery and regain some of her sight. Another colleague went for 2 decades with debilitating pain in her back before she got Medicare and was able to have surgeries to relieve some of that pain. So the private healthcare system is torture for many people.
Thank you, Mr.
AB 1400 is the answer.
Thank you. And Craig Simmons, you'll be our last speaker. Please go ahead.
I'm Craig Simmons. I'm calling from Los Angeles, and I'd like to address the question of perception, which was brought up by Dr. Galley and Anthony Wright. You know, in California, higher taxes are always perceived as a burden. So my question is for the consultants, if they would consider polling the population as to whether they would vote for a payroll healthcare tax to fund a unified financing system, assuming that Medi-Cal and private and employer-provided insurance all remains the same. Thank you.
Thank you so much. And with that, I'll turn it back to Secretary Galley to adjourn our meeting.
Yeah, Karen, thank you. And thanks to all of the commissioners for another really great conversation, to all the public who tunes in and provides their input and insights. I think, as always, it's incredibly supportive and challenging at the same time for us to continue to try to do this work. So with that, let's wrap up. I hope everybody has a tremendous Thanksgiving week holiday. If you're traveling, be safe. And I look forward to getting together again in the first part of December. I think it's the 9th for our next meeting. So until then, thanks again and be well.